Good morning, good afternoon, good evening, wherever you are in the world. My name is Maurizio Cecconi. I'm the president of the European Society of Intensive Care Medicine. I'm delighted to be here to open the grand finale of the Datathon 2022. Let me just start by saying thank you particularly to Ari Ercole, Paul Elbers, and all their teams from the data science section of ESICM. It is the youngest section, but it's a very, very active section, and it's amazing what you guys are doing and what you've been doing even during the pandemic. It's fantastic to see so many clinicians, so many data scientists getting together to learn, to challenge each other in a friendly environment. Thank you also to the Office of the European Society of Intensive Care Medicine and all the technical teams, and also to GE for the unrestricted support to this event. I was just looking at some of the research that has been going on and some of the abstracts of the team that they will present today. And it's really incredible to see how in a short period of time, people can get together bringing clinical skills, research skills, coding skills, really to bring high profile research on this. Without losing any more time, really, I just would like to wish everyone a fantastic grand finale. I'm going to be watching. I'm sure that we will hear and see fantastic research, great presentations around data science. And I would like to welcome Ari Ercole to talk about the start of this datathon.
Thank you, Maurizio. And again, I also want to echo your thanks to particularly the ESICM office staff, and especially Margot, Estelle, who we just could not have done this without you. So thank you so much for that. That's absolutely fantastic. And also, yeah, so we as the exec have spent, well, today and it's the evening reading the abstracts. And I'm not looking forward to judging this, to be honest, because once again, yet again, I have to say the quality of the work has been extremely high. And I'm really not just saying that, very, very, very impressive. What people have been able to pull off in a month. And of course, it's not a month of just pure work. It's a month working around busy jobs that we all have. So enormous congratulations to everybody. And we'll talk a little bit later about, at the end of today, it's not necessarily the end because people can carry on. And we will explain a little bit about how that can happen later this afternoon. But in terms of highlights, I mean, amazing amount of work. Just for those of anyone that's watching that wasn't familiar with how we've done this, we set the 16 teams to choose one out of 3 different tracks. We've chosen these tracks specifically because we think that the data is available in the database that we're using. So track 1, looking at lactate in the intensive care unit. Track 2, looking at acute kidney injury. And track 3, looking at low tidal volume ventilation. I think you'll agree are all crucial core aspects of intensive care medicine. And the teams have really attacked on diverse problems with that. And what they've used is data. This is the second outing in a datathon for the Amsterdam UMC database. And again, just to call out, this is the first ever freely accessible European database of full intensive care records. There's 23,000 patients worth of data in this. So really impressive resource and generated some fantastic results from last year as well. But it's not just been about research. It's not just been about coding and clinicians learning to code and data scientists learning about clinical topics. What I think is actually really remarkable about this format of Datathon, and to be honest, we came up with this format of doing things over a month, doing things virtually as a result of COVID last year. There was no choice. But in fact, it's worked really, really well. And what you will have learned is the difference between a whole new way of working, really. So something that's very unfamiliar to us as clinicians, we tend to work in this kind of waterfall paradigm that you do one thing, you have a set sequence of things that you do in research. You do one thing, then the next, then the next, then the next. Whereas actually what the teams have done is they've used platforms, they've used Slack, they've used video conferencing platforms to work collaboratively in much more of a sprint agile kind of way, attacking a problem and coming back and seeing how far they've got and attacking the next problem. Very different way of working that's much more familiar from the software industry and other areas of industry, but actually really, really useful when you're trying to use data science to tackle problems in clinical practice as well. And just to sort of prove, that people have been working. We've had a Slack as a platform to manage discussions. It's a searchable kind of way of messaging each other and sharing data, sharing information, and us assisting people. And here you can see the number of members and the numbers of members who are posting things over the month of the Datathon. You can see that people pretty rapidly got up to speed over even just a few days in terms of posting, and then have been a sustained effort over the month. Messaging each other and actually collaborating and working on these problems. It was really impressive and good to see. And in terms of some numbers, there have been over 7,000 messages sent between people, and that's generated about 0.4 of a gigabyte of discussion over last month, which is really impressive. And these are people working across multiple time zones as well, nevertheless producing output. That was very similar to last year. One thing that's been different this year actually is the way that people have used things. There's much more sort of posting things in private channels, maybe less sort of collaboration in sort of open public channels, but the collaboration has been continuous all the way through the month. So we started with 16 teams. We've come down today to 9 finalists that have submitted their abstracts, which we've been reading. As I say, really, really high quality. I'm not looking forward to making a judgment over this or help with the others, but it's going to have to happen, because at the end of today we're looking for 3 winners from today's Datathon. So without any further ado, we will move on. The format, I seem to have gone into infinity there. The format for today is going to be, we're going to, each team is going to give a presentation of a maximum of 10 slides, 6 minutes each, and we're going to keep it pretty rigid to that, because we want to make sure that everyone has the same fair width for everything, and then a maximum of 4 minutes discussion after each presentation. And so we're going to kick off with team number 6, which is Givithon, and it's Jonathan Montemorli who's going to be presenting on their behalf. And team 6 is going to present on the subject of understanding acute kidney injury during ICU admission. Let physiology be the guide. Jonathan, over to you.
Yeah, thank you. Good afternoon. I have a bit more than 10 slides, but I will stay in the 6 minutes. So everybody, the kidney depends on local factor and systemic factor, and it has a particular vascularization. So usually we measure creatinine as a marker of glomerular filtrate, but we have to remember the relation is not linear at all. And the other parameter that we usually measure is urinary output, that mainly depend on glomerular filtration, tubular resorption, and tubular suppression. Moreover, we have factors that can influence, for example, the ADH with a short half-life of only 15-20 minutes, so can provoke changes in the urinary output quite rapidly. So we took the Codigo classification for ACI, and we split only considering creatinine and considering creatinine plus urinary output. We consider patient with ultra-impaired creatinine as admission in a group apart, and then patients with normal creatinine were at risk for developing AKI stage. So when we look at the incidence of AKI using the 2 different classifications, we can see that the incidence changed markedly. For example, with AKI stage 2, when we use only creatinine, we have 1% of incidence, while when we use AKI 2, it goes up to 13%. And the similar pattern is for AKI 3, that pass from 1% to 3%. And we look briefly at the use of furosemide when we consider only patient with impaired creatinine is really low in the database, while when we look patient with oliguria, we have a bigger amount of use of Lasix. So then we look at the prognosis based on the 2 different classifications, and we can also see that the different way we classify AKI has an impact on prognosis, especially for AKI 2, where when we classify patients using only creatinine, the mortality is near 40%, while when we use urinary output plus creatinine, the mortality goes markedly down. And then we look at the AKI evolution. So we focus on the AKI creatinine classification, and we look at the evolution. So there are a majority of patients that never developed AKI and were discharged with no AKI, while patients that develop AKI. And we also look at the patients that enter with renal impairment. If they normalize creatinine within the first 72 hours, then they were put at risk for AKI. And actually, we look in the different groups. The partners for the majorities of the database are patients with cardiac surgery. So we split them from all the other, and you can see that the evolution of AKI is quite different. Then we focus on patients that enter with an impaired creatinine, normalized, and they develop a second AKI during ICU admission. And then you can see is quite differences that patients that solve the renal impairment and never develop AKI again, while patients can develop AKI 1, 2, and 3. And so the overall mortality in this group is 15%. So then we try to use a multidimensional cluster to describe if using only parameter at the ICU admission, we can predict the patient that will solve the renal impairment. And we use a multidimensional cluster, and we then describe in a 2-dimension. And you can see there is a clusterization where in the 2 cluster in high and on the right, they can clusterize patients that will not solve renal impairment. While, for example, for soft cardiovascular, the clusterization doesn't work well. This can be the sign that individual variables are not clusterized, but when we take together, they can clusterize patient and predict the patient, identify in an unsupervised way the patient that will solve renal impairment. And then we also want to predict the final outcome of this patient during ICU admission. So we built a random forest using an adjustment method that redistributes the different among the groups. And actually, we were predicting the 3 outcomes, like being discharged alive but under renal replacement therapy, or or never discharged, so dying during ICU admission. And so the best prediction for the model was for predicting patient discharged with renal replacement therapy. The ROC curve was 76%. The worst for dying patients, 67%. And then finally, we look at the risk factor, and you can see in blue patient the not modifiable risk factor that has a similar behavior both for predicting discharge with RRT and for predict death. While when we look at the modifiable features, there is really a strange behavior. It seems they change a lot the prediction with of RRT and death, and they also, when we consider those as 24 and 72 hours, their behavior change a lot. We are going to look more into that. First of all, we have to remember that the competing risks should be taken into account, because patients that die, they cannot develop RRT, even if we use a multinomial model. And the other fact is that these features are aim of our treatment. So it can be that we improve SOFA cardiovascular score, or we improve coagulation, but this has not a physiological impact on our patient. On the contrary, it can be what we call aesthetic treatment, when we see the lactate that go down, the cardiac index that improve, but actually at the end, this therapy does not improve the prognosis of our patients. So we go back to this quote by Gattinoni, that physiology is the only polar star we have, and we should go back to understand and to better describe and to better evaluate physiological process to be able to better treat our patients. So I want to thank all our group that has really worked hard for this 1 month, and I open for questions.
Thank you, Jonathan. Really nice work. And actually, it's really nice to see a descriptive of that of the data set, which has not been done before. And can I encourage you to do 2 things? One is to publish your AKI on GitHub, and preferably in a journal as well, so that people have access to that, can reuse that code and comment on it. And the second thing I think you should do is actually publish your descriptives of this population in the database and those Sankey diagrams. I have one question about the UMAP plot that you've got. Do you have any interpretation? You have quite a lot of clusters that UMAP found. Do you have any interpretation of what kinds of patients those are? What those clusters represent?
Well, no, really, we have to describe the cluster, but we see that at least, in the meaning that we analyze all the variables that we use to clusterize, and actually there was no variable that really clusterized as well as the predicted one. Yeah. So it seemed that we just decide the variable based on the frequency in the database, because we have a lot of missing, so we have to completely discard the respiratory SOFA. and based on literature. So, but we have to describe better the patient. I mean, I'm come from clinical epidemiology, so I'm really obsessed on the analysis of databases, understanding descriptive analysis. I think is 70% of the work. So we have planning to publish, to go ahead, to work on other databases also, to see if the finding is consistent around the world.
Perfect, very good. And any questions from other panel?
Yeah, I just want to, impressive work, Jonathan. I also like the swanky diagrams, and it actually made me realize something that I didn't realize before, which I should have. So we're actually focusing usually on trying to prevent patients to develop AKI, right? But in fact, many patients come in with AKI and then they either recover or not, right? So that is immediately clear from those diagrams. So I also have a question about the clustering, but maybe even more importantly, so do you think these classification systems that are currently in use, so KDIGO, ECIN, etc., are they at all useful? Because they seem to be associated with such different outcomes in the database.
Yeah, exactly. I mean, you open a really good question for me. This is a topic I want to explore, and I have explored. I think there is different ICU, acute kidney injury, but patient before entering ICU, mainly they are hypovolemic, they have to be optimized. So they have some kind of impairment that usually is not renal. And then during ICU admission, we have completely to recode a new AKI classification working for, septic patient, probably they're different from trauma patient. They have really completely different patients. So we have to focus on good data that describe the kidney from different point of view, together with hemodynamics, to really classify an AKI with prognostic impact for our patient.
And about the clustering, right? So we saw these clustering diagrams, right? So this is a question to help clinicians that are currently watching that are not so much used to these diagrams. Can you maybe tell them what they mean?
Yeah, I would. I mean, it's not exactly describing what we use, but I can say we made the Pythagoras theorem, where you compute. You take the two catheter, and you compute the hypotenuse. And then you image to be in a multi-spatial model where you don't have only two axes, but each measurement you take is one axis. So you have a space formed by 32 dimensions. And then you describe the distance in this 32 dimension, and then you try to go back to the reality and put in a paper where you have only 2 dimensions. So it's a sort of going from a difficult existing system that is only virtual, to something that is describable, that is possible to describe in the reality. I don't know if
and then some doctors might ask, how can I use this at the bedside?
I think, as I told in the beginning, all these things, I really like a viewpoint on JAMA that I would suggest to read, is called the wayfinding approach to using data scientists. That is like, we don't have to predict mortality. We have to understand better physiology, to understand what we are not doing correctly. So I think this cluster helps us to understand, what we can measure. In some way, are we able to clusterize? So, data we are collecting are able to identify something that we don't see. So we have to go back and understand what we don't see, and how can we see what just big data can say to us, but we're not clinically identified. So I think it's really a back and forth process where we understand, when we define something and we try to explain back.
I agree. And one might hypothesize what you found are, in some sense, phenotypes of something. And it's reassuring that your renal behavior correlates with the phenotypes that you found. It doesn't prove that you've got a phenotype, but it is at least biologically plausible if you found something that is a phenotype, that it should correlate with some sort of outcome or some sort of other behavior in the group, which is kind of reassuring, I guess.
Yeah. And I think also, we do a lot of things. We see patient treated with the best of care. So we have also to consider that we are predicting patients that are already treated. We are not investigating natural history of pathology.
Agreed. Fantastic. Jonathan,
thank you.
Many thanks. Fantastic presentation. I think we'll move on in the interest of time. And the next presentation also is by Alex Fabregat from the team Plague Doctors. This is on different track. This is low tidal volume thresholds and trajectories amongst critically ill patients. Alex, take it away.
Hi, thank you. I'm Alex Fabregat, and I will be presenting on behalf of the Doctors Plaque team. The title of our talk, Low Tidal Volume Thresholds and Trajectories Among Critically Ill Patients. Oops, sorry. So the motivation, sorry, just give me 1 sec. Yeah, here you are. So lung protective strategies using low tidal volumes have become the standard of care for patients requiring invasive mechanical ventilation. This is illustrated in the panel on the left. The result is taken from this reference. In the vertical axis, you have mortality versus tidal volume. And these results suggest that either too high or too low tidal volumes is associated with higher mortality. So we have this U shape. But the question remains, how low is too low? Usually, most of these approaches use this cross-sectional approach, but we think that time needs to be considered because it may be playing a relevant time to understand the dynamics of these patients. So the aim of our aim is therefore to assess whether lower tidal volumes impact mortality among patients receiving invasive mechanical ventilation using machine learning and the Amsterdam UMC database, which is summarized on the box on the left. The inclusion criteria summarized invasive mechanical ventilation during the ICU stay and exclusion criteria invasive mechanical ventilation for less than 48 hours. We are left with roughly 4,000 unique admissions. This is going to be our working data set. The primary outcome is going to be all-cause mortality at 28 days since admission, and we are going to stratify patients based on simplified specialty. So the first thing we are going to do is the most simple statistics. What we can do is take the cohort average tidal volume normalized by the predicted body weight in milliliters per kilogram in the vertical axis versus the hours of invasive mechanical ventilation for survivors in blue and non-survivors in red. And as expected, because otherwise we wouldn't be solving this question, is that these two curves actually pretty similar to each other, except maybe for the first days of invasive mechanical ventilation where there is some differences. In summary, the lessons from this basic data is that the majority of the cohort average tidal volume data points lie inside this 6 to 8 milliliters per kilogram stratum with a small fractions of observations beyond these limits. And the fluctuations that grow as time goes on, as time increases, suggest that there may exist patients groups with different dynamics. We can take a look at this more or less the same data from using some basic statistics. We can plot the probability density function on the left, or we can plot the fraction of time under invasive mechanical ventilation for each tidal volume strata, but the message is essentially always the same. Globally, differences in mortality associated to differences in tidal volume are very limited, and these differences remain modest even after stratifying by the time spent in each tidal volume, SOFA, Glasgow Coma Scale, and so on and so forth. So we need something a little bit richer. We need to gain insight. So we decided to go for this unsupervised learning because we thought it's appropriate strategy given the nature of the question, how low can we go? Distinct response among patients to lower tidal volume could be addressed by identifying naturally differentiated subcohorts, this is the clusters, using basic respiratory, clinical, and demographic features. We clusterized the data with the K-means for each specialty, and from previous analysis that I'm not going to talk about because of the sake of time, the optimal numbers of clusters was conveniently B2, and we took to carry out the clusterization, we used data at 48 hours after the intubation. And these are the results. So each of these panels correspond to a specialty, and you have two columns here. The column on the left is the centroid. This is the average across all the points in that cluster. So on the left for cluster 1, on the right for cluster 2, for each specialty, and then the color indicates the relevance. So the more reddish it is, the more relevant it is in segregating these two clusters. Yeah. Most of the 11 predictors are self-explanatory, except maybe the weight departure in kilograms, which is the difference between the actual weight and the predicted weight, the ideal weight. For instance, in the case of cardio patients, we can see that in cluster 1, the centroid is 7.3 kilograms, so slightly overweight, if you want to put it like that. And in cluster 2, this weight departure is actually significantly larger. The second predictor in importance would be the PIP set value, and so on and so forth. And now, equipped with these results, we can actually go for the real deal. Yeah, so this is the main result. In this case, we do it for the cardiology, for simplicity. And what you can see is two panels here. The panel on the left for cluster 1, panel on the right for cluster 2. And on the horizontal axis, you have days since invasive mechanical ventilation. And what you have in the vertical axis is simply the number of survivors at 28 days. In order, because both clusters may have different sizes, to make a fair comparison between clusters, we are normalizing by the cluster size. And each of these colors correspond to below 4 milliliters per kilogram in red, 4 to 6, in yellow, 6 to 8 in green, which would be the the guideline, so to speak, 8 to 12 milliliters per kilogram in blue and above 12 in purple. And the results clearly suggest that the 6 to 8 milliliters per kilogram is the most adequate strategy, because it's the one that maximizes the number of survivors. However, there are differences between striking differences between cluster 1 and cluster 2. In cluster 1, the patients, if you lie in cluster 1, it seems that using a slightly lower tidal volume strategy, let's say 4 to 6 in yellow or 8 to 12 in blue, is going to yield a survival rate more or less close to what you would have with 6 to 8, these guideline values, so to speak. And definitely, it's a really bad idea to go below 4 and above 12, because the mortality rate is actually significantly larger. Cluster 2 is completely different. If you look at the results, you're going to see that in this case, using a tidal volume of 4 to 6, a slightly smaller tidal volume is actually not advisable at all, because the survival rate is going to be significantly lower. As you can see, that this yellow line would be way below the green one. So just to wrap up, the role of tidal volume on mortality 28 days has been investigated using unsupervised learning. Data from 11 predictors at 48 hours after intubation have been used to identify 2 clusters of patients. 6 to 8 milliliter kilogram is found to be the most effective in maximizing the survival rate of critical patients with invasive mechanical ventilation. And to specifically address the question of track 3, moderately low tidal volume values below 6 milliliter per kilogram might be beneficial for patients with near predicted body weight values, low to moderate PEEP and peak pressure values, and to a lesser extent, moderate SOFA scores. Extreme values above 12 and below 4 milliliters kilogram are not found to be effective for any subcohort. And that's it. I would like finally to thank the organizers for this outstanding datathon and wish the best of luck to the rest of the teams. Thank you.
Thank you, Alex. Great, really nice results, nice approach. My question to you is, to what extent do you think this is causal, the inferences you're pulling out, and to what extent do you think it might be the result of unmeasured confounding, unmeasured factors that have meant that a particular ventilatory strategy goes
Yeah, that's a really good question, and I cannot answer because we haven't. That would require a deeper analysis of the results. The thing is that in our case, we had to spend significant amounts of time trying to identify an intubation and extubation to actually find these streaks of invasive ventilation. Yeah, so that took a little bit of time. It was a little bit tricky, and definitely what we actually we think that the results are promising in the sense that it seems that this analysis allows to define some differences, some specific characteristics and behavior depending on the type of the patient. So we think that maybe there is something there, but definitely we need to explore this thing further, because at this point,
it's interesting that the thing that's differentiating is something that you would also expect to have an impact on your choice of ventilatory strategies, so that the weight of the patient you would expect to influence the clinicians when they're actually potentially ventilating somebody on the basis of their actual weight rather than their predicted body weight, because it's the weight that's differentiating. Any comments? I should just say, I mean, if you've got code, I'll say the same things I just said earlier. If you've got code for finding the extubation dates and so on, again, these are things that are worth publishing and making available to future users to speed up research in the future. Any other comments from other panelists?
Well, can I ask you, Alexandra? First of all, great presentation, thanks, and great work the last 3 weeks. Can I ask you, so how do you get from the clustering algorithm to the more or less causal conclusion that 8 to 6 milliliters per kilogram is best? That's the connection that I cannot yet really make in my head. Okay. Can you explain a little more?
Absolutely. We take the data at 48 hours after intubation, and we create these 2 clusters. And then with these 2 clusters, we can tag every admission ID. Then we know if it's in cluster 1 or in cluster 2. And then as time evolves, we have less and less patients because patients are discharged. So these curves naturally have to go down. But what we do is simply count how many survivors do we have each day on each of these tidal volume strata. That's the only thing we do. Of course, because the 2 clusters may have relatively different sizes, to make the comparison fair, we actually need to normalize each of these 2 plots, each cluster, by the initial size. And that's it. We just count the number of survivors at 28 days as long goes by. After identifying them, with this cluster AD.
So you see that the cluster in which patients are more likely to be ventilated with 6 to 8 milliliters per kilogram are more likely to survive. Is that it?
Yeah, the message is, when we look at cluster 1, we can see that if you go to lower tidal volumes or higher tidal volumes compared, I'm using as a reference 6 to 8 milliliters per kilogram. Yeah, it seems that patients in cluster 1, the survival rate is going to be closer to the 6 to 8 guideline value, so to speak. Yeah, and then we can go back here and check what is the characteristics of this patient. Yeah, so in the case of cardio that you have on the leftmost panel, yeah, it seems that if you're in cluster 1, this is, for instance, if your weight departure is modest with respect to the predicted body weight, you are in a better position to actually go for a slightly lower or a slightly higher tidal volume. On the other hand, if you're in cluster 2, this is going to be a really bad idea, because as you can see, the survival rate for, let's say, 4 to 6 in yellow is way, way lower than the one that you would get with 6 to 8 milliliters per kilogram in green.
Right.
Alexandra, so how can I then, how can I best know in which cluster my patient is, right? So it was based on the 11 features, right?
Yes, these features that you have here.
Yeah, we don't see the presentation, so you need to talk a bit about them, because we cannot see the screen and the live. We have seen your presentation when you presented it, but now we're in a sort of a discussion mode. So we need to make sure that the audience can understand us by just describing these features.
Sure. So the clinician would need to know what is the weight and what is the departure from the ideal weight, what is the PIP set value that you are using, what is the SOFA score, what is the age, what is the height, and then this is naturally going to classify that patient either in cluster 1 or in cluster 2. Yeah. And according to this classification, then you may decide if you can go for one or the other option. This is if it's advisable to use lower tidal volume, or if it's not advisable at all.
Yeah, and again, so I'm actually reiterating, of course, Hermione Ari. So again, comes to mind the question of causality, right? So it's easy to imagine that these features that determine in which cluster you are in may also somehow determine the preference of doctors to use a certain setting and at the same time be associated with a certain outcome. I still think it's very interesting, but I still have doubts about the causality as the other panelists do.
Oh, okay, I don't know if this was a question.
No.
Alex, thank you ever so much. Beautifully presented, and again, I encourage you to write some of this up. We'll move on to our next speaker. The next team is Team 14, C2C, 2CC. And that presentation, I'll just get my thing up. And the presentation will be on strike a perfect balance. Can one size fit all the kidneys? Again, from the AKI theme, and it's Chris, I think.
No, it's me.
Oh, I'm sorry, Tomek.
Good afternoon, guys. Yeah, okay. Can you see my presentation?
Not yet.
Is it there?
Yes, there we are.
Okay, thanks. So my name is Tomek Krulitsky, and I'm a resident in anesthesia and critical care, and I will present you on behalf of my team the results of our work on topic 2, hold on to your nephrons, and our research is named as following. So to give you a brief introduction into the topic, sepsis is one of the most common reasons for ICU admission, and an event which may be developed by patients admitted to the ICU. Additionally, septic AKI, so septic acute kidney injury, is an adverse event in the course of the disease that significantly worsens the patient's prognosis, is associated with higher mortality and increased healthcare costs. In our study, our main objective was to focus on treatment modalities, interventions, and possible factors that might mitigate the renal burden in patients in ICU with sepsis. Our study is basically a retrospective review of the Amsterdam UMC database, and it included all cases of sepsis in patients admitted to the ICU. The diagnosis of AKI was based upon the KDIGO 2012 criteria, and based on those, we have divided all the patients included in the study into two groups, which were named AKI and non-AKI, with the following sample sizes as presented on the screen. The main outcomes in which we were interested was, of course, the occurrence of AKI, and we have not distinguished it on separate stages. It was just the development of AKI or not. Then we have analyzed the 28 days mortality, need for renal replacement therapy in the ICU. So we will move now to the key results. As we have actually begun to look at those data, we have realized that a significant proportion of patients have already presented with AKI on admission to the ICU. To visualize that, we could recognize it by the fact that the serum creatinine was already elevated in those patients. And after that, in the course of the disease, they have presented with oliguria and anuria. That's why we have concluded that it would be best for the study purpose to concentrate on the first 22 or possibly 48 hours of treatment, because it includes the phase of sepsis resuscitation. As you may see in the table, both patient groups did not differ significantly regarding the baseline population characteristics. The patients have presented with similar MAP values, had similar hemoglobin, even CVP pressures. However, the treatment and the amount of transfused fluids in both groups was significantly different. Patients in AKI group have received about 51 milliliters per kilogram of fluids, which is a sum of crystalloids, colloids, and hydroxyethyl starches. Meanwhile, their counterparts with intact renal functions have received only 63 milliliters per kg. The mortality was, of course, higher in the AKI group, and it accounted for about 56%, with 29% mortality in the control group. At the next stage, we have looked on some hemodynamic trends in both of the study groups. And as you can see, both AKI and non-AKI patients have started with similar MAP values. However, in the course of treatment, patients with AKI have presented significantly lower mean arterial pressures despite resuscitation. On the next two graphs, you can see the plots presenting the pulmonary capillary wedge pressure and central venous pressure in both patient groups. And similarly, both of these pressures were higher in patients with AKI. However, they have gradually equalized over the time of resuscitation. That led us to a conclusion that perhaps some amount of patients was over-resuscitated because of the rising and already elevated central venous pressures and pulmonary capillary wedge pressures. Therefore, we have analyzed the prevalence of AKI in all the study patients according to fluid transfusion strategy. As you can see on the first graph, patients in whom a liberal strategy was implemented, meaning who have received above 30 milliliters per kg fluids, have presented the highest proportion of AKI. They have also presented the highest need for dialysis in the ICU, which reached about 3.6%. In patients with moderate approach, so about 20 to 30 milliliters per kg in the first 24 hours, the outcomes were best in regard to prevalence of AKI and need for dialysis. Meanwhile, in a restrictive group, those outcomes were slightly worse as in the moderate. Then we have investigated also the impact of norepinephrine and hydrocortisone treatment in all of those groups. And as you can see in both of the cases, the introduction of those drugs was associated with higher mortality in all of the study groups, regardless of the amount of fluids they have received. This is most probably associated with the fact that those patients were probably the sickest ones, and therefore they have received those drugs as a rescue. At that point, we actually had no other proof or possible analysis to employ to confirm our findings. Therefore, we have chosen a machine learning approach, which is named temporal fusion transformer, due to some advantages it offers, which include enhanced interpretability, reusability, and the fact that it analyzes variables in a time-wise manner and modulates everything for a continuous outcome, which in our case was urine production. The results of this analysis are shown on this plot. Point 0 on x-axis represents the time when AKI could have been diagnosed by the urinary criteria, and the lines represent the relative variable importance in the course of the disease. As you can see, variables which were most significantly associated with our outcome were mean airway pressure, which might also be associated with over-resuscitation, the use of lactated ringer, and the use of isotonic saline, which is generally congruent with what we have seen in our data. So to conclude, our study has shown, naturally, it has not shown a causal association, but just an association, that fluid resuscitation with balanced crystalloids instead of 0.9 saline, using volumes of 20 to 30 milliliters per kg in the first 24 hours of resuscitation phase of sepsis, seem to carry the most impact on preventing septic acute kidney injury and the need for acute renal replacement therapy in the ICU. We couldn't actually determine the possible impact of implementation of norepinephrine and hydrocortisone treatment on the kidney outcomes in this patient group. Those results are generally not congruent, which is quite surprising, with the sepsis guidelines, which since 2012 indicate that the initial volume for sepsis resuscitation should be at least 30 milliliters per kg of crystalloids. And this recommendation has been also played in the newest guidelines. So that's what we have got after this month of work. Thank you for your attention. And still we are left with a question, how much fluid is then enough? Thank you.
Thank you, Tomek. Beautifully presented. And again, congratulations, I think, for using things like fluid balance, which are really, these kinds of variables are really difficult to extract and work with. So yeah, nice piece of work. I think I'd struggle a little bit with the causality of this, or trying to, I mean, I know you're not suggesting a causal nature, but I think one has to be a little bit careful with the sorts of modeling that you've done to, I mean, it is hypothesis generating rather than anything else, so just be a little bit careful on how you phrase that. I'm interested with your machine learning model. Some of your variables change their significance depending on look back time. Some of them remain similarly significant at different temporal times looking back. Any thoughts on why that might be, or whether that's significant or interesting?
Yes, generally, when analyzing those data, we have thought that, may I show you this plot again? It
Sure.
will be easier to understand, perhaps.
Mm-hmm.
For example, in case of saline, the relative importance was highest far away from the diagnosis of AKI, and has been decreased over time. This might be possibly associated with the fact that saline is not perfectly balanced. It causes hypochloremia, it causes acidosis, which are factors that possibly contribute to AKI development. Meanwhile, the importance of Ringer's lactate, which was the only balanced crystalloid which was used in those patients, increases over time until the point where AKI is diagnosed. So it is possible that balanced crystalloids might in some way prevent the development of ACAI by preventing acidosis and all the negative effects of saline that might be implemented by like an aggressive resuscitation with high volumes of pure saline.
It's an interesting hypothesis. I mean, I think, of course, the other elephant in the room hypothesis is that there may be something structural about how these fluids are used in particular patients or in particular sequence. But it's interesting. And you could look at, if you're interested in the acid-base balance, potentially, you have markers in there of metabolic acidosis. So there's things you could do to see whether, how that develops as well. Any questions from the other panelists?
Yeah. So again, thank you, Tomek, and to repeat Ari's message, we would be extremely happy if you could post some of your codes on the Amsterdam UMC DB GitHub. And of course, like with previous teams, I would also encourage you to proceed to try and get this published, because I think it's definitely possible. Anyways, I also like very much that you're trying to challenge the surviving sepsis guidelines, although again, maybe the causality issue is still a thing. But to make sure that you're doing that in the right way, I noticed that you found about 22,000 patients with sepsis in the Amsterdam UMC database, which seems to be a little funny because there are only 20,000 patients in general in the database.
Yes, I'm aware of that. We have included cases of sepsis diagnosed in ICU, not patients admitted to the ICU who might have had multiple episodes of sepsis. That is the most probable reason for this discordance in those numbers.
So when you talk about number of patients, do you mean number of episodes? I'm trying to understand because there are really only 20,000 patients in the database.
Several patients have developed sepsis for a couple of times.
Okay.
Several of them were readmitted. That's why those numbers are higher than the initial amount of patients.
Okay, yeah, you treat them as individual episodes, right, in your analysis, which is probably doable. Okay, right. And then another technical question. Also, you examined the effect of hydroxyethyl starches, so HES. And yes. So in my recollection, because I work at the hospital from which the database was derived, there was also a lot of gelatins used, so yellow fusion. Did you maybe take a look at that too, or did you not separate that from the hydroxyethyl starches?
Yes, we looked at that. Indeed, the gelfusin was the main colloid that was used in those patients. However, we did not present it separately from the remaining colloids. As far as I know, gelfusin is not associated with possible kidney damage. So, like we actually had to limit the amount of data that we were presenting on this presentation.
Yeah,
so it was not possible to show all those data.
That makes sense. Thank you once again. Harmjan, do you have a final question?
I was interested also actually in colloids, and the fact that you found really the least important variable seems to be the hydroxyethyl starches. While that's one of the variables that we think is important, but do you have any idea about why that may be?
Yeah, thanks for this question. Actually, I believe that the low relative importance of hydroxyethyl starch is caused by the fact that very few patients actually received it. What you can see in this table were the direct amounts, like mean amounts registered in the whole study group, and not the amount of cases. So if you take into account a low amount of patients, it does not pose like a big effect on the whole population.
Yeah, so
That's
it's
probably the
the
reason.
importance on the population rather than the importance for any individual patient.
Yeah.
Okay, figures. Thanks.
Thank you.
Thank you so much, Tomek. And it's also amazing to see that we're running right on time. So it is my pleasure to introduce our first keynote speaker of this afternoon. We're very lucky to have her, Professor Azra Bihorac. And why is this? Because she has been an amazing pioneer in the field of precision medicine, combining a plethora of techniques in the domain of machine learning, artificial intelligence, and intensive care medicine. Also a lot of renal research. And she's recently, I think at the end of last year, she's been named Senior Dean of the University of Florida. And that is most likely because she has published enormously. I think I've seen now over 200 papers. I think the citations are currently not countable anymore. So it's pretty great that she has found the time to join us and to teach us about precision medicine, and this time specifically about phenotyping, because that's hip, hot, and happening. So Azra, without further ado, may I give you the floor?
Thank you so much, Paul, for introduction. You guys can see my slides, right?
Yeah.
Excellent. Yes, well, I just in November took a role as a Senior Associate Dean for Research, so administering, like making impact by enabling new investigators at the University of Florida. And we are very lucky to have a AI initiative that was actually sponsored by the big donation from NVIDIA. And not just that we got the most powerful computer, but we are also recruiting 100 AI faculty at the UF, including 25 at the College of Medicine. So that's really amazing. So hopefully that will help us, partner with more people on a national, international level and really attack this field. I think critical care makes sense to all of us. It's a very mathematical and computational field. And thank you for inviting me. We are organizing Datathon at the UF in September, and we can learn so much from you. Paul and Ari, you were really leaders in this field, and I really appreciate you having me here. Hopefully one day I'll be able to do in person. I'm hoping to start traveling again. So let's start talking about what was assigned to me, the big data for sepsis phenotyping. I try to just quickly in 15 minutes summarize to you what I think has been done in the field. And let's start a little bit with the background that, as you all know, many trials conducted in the ICU have failed to identify treatment benefit, but we believe not only because we don't have adequate drugs, but also perhaps we don't understand completely mechanism of underlying heterogeneity of critical care syndrome, and not just one syndrome, but many syndromes that affect multiple organs in single time or multiple times. So in my opinion, it's both problem of refining a cohort that are more pure in terms of pathophysiology and mechanism, but also finding a new drugs or new combination of the treatments. Again, precision medicine has this noble goal of trying to streamline underlying biological mechanism of the complex diseases and then match them with adequate treatments. How has machine learning entered into all of this is by the use of, a lot of us have done on the supervised learning when we have a well-labeled cohorts with the outcome that we want to predict and treat them as a classification problem. The unsupervised learning was for a long time utilized in the genomics and transcriptomic analysis because of the highly dimensional data sets, but it hasn't entered the clinical arena of the clinical data research. And then we have reinforcement learning that is also making entry into the critical care medicine. Now, the unsupervised learning most commonly used one that you will find in the paper is the clustering analysis. That's a form of the unsupervised learning that has been used to explore, characterize disease and patient clusters, or are sometimes called phenotypes, endotypes, depending what data you consider as an input data. There is a lot of really confusion in the field, in my opinion, in terms of the precision of the names we use and what they really mean. The unsupervised learning, as opposed to supervised learning that has a clearly labeled data, takes unlabeled data and then using machine learning recognition of the association with the data points, try to assemble data based on similarity, as you can see here in the similar groups 1 and 2. So Primary application, urea clustering, a lot of different clustering algorithms based on a similarity of data points, and lately in the last several years, with the entrance of deep learning and representation learning from the data and embedding of the data patterns in the models, we have started using encoded representation, the data where data is transformed into vectors, and then vectors are being assembled in the clustering algorithms based on their similarity. We are seeing entrance of that type of the research that by itself has a lot of challenges that I might mention later on in the discussion. Besides clustering, such as k-means clustering, hierarchical clustering, Gaussian mixture models, representation learning in a conventional machine learning use principal component analysis or a singular value decomposition to really decrease the dimensionality before you look for similarity. And then in deep learning, we use autoencoders, deep belief networks, or generative adversarial networks to really represent data in more simplified form before we apply some similarity patterning on that. Recent paper, interesting paper published in 2021 by Merle and a group of other prominent investigators in the field talked a little bit about what should be a framework for development and interpretation of the subclasses of the sepsis patients, with understanding that we have a very heterogeneous syndrome that might be conglomerate of all kinds of subgroups, and then how we understand what are these subgroups and based on their similarity, but not only in the clinical presentation, but the response to treatment, underlying mechanisms, and so on. So empirical approach, what we have done for years using our expertise as the clinicians and our empirical observations and data from epidemiological studies. So we divide sepsis based on agent, clinical settings, and so on. Hypothesis-based moved us from empirical classification to observation experimentation using data from animal studies, cohort and RCTs, and that's very much what the transcriptomic field has done, using, in many ways, hypothesis-driven under study of mechanism, and then trying to explain them with some underlying mechanistical hypothesis. And then what they propose calling agnostic really is data-driven, using different type of the computational approaches that look for similarity in data that are unseen or unrecognizable by human experience, or hypotheses that perhaps those approaches can provide us with some novel hypotheses, or maybe circulate us back to the old ones. Again, that was another transcriptomics profiling using a supervised analysis, like in a Mars endotype by Cicluna papers, or CMOS paper that use clinical data to cluster patients. So really, how do you call all this? Is it endotype? Is it phenotype, subphenotype, subtype, endophenotype class? I think at the end, in my opinion, we do have a lot of heterogeneity. We need a more unifying classification scheme, and I think we also need to understand what exactly we want to achieve with this. This is this recent systematic review that one of our medical MD PhD students did with Dr. Tyler Loftus, my mentee, looking at the papers that did phenotyping of adult patients with sepsis and septic shock. You can see here on the left side, they reviewed papers for the potential bias assessment based on the rigor of the scientific methodology. And I listed on the right side all the studies that got a green light, meaning that they were completely free of bias based on the criteria they applied. As you can see here, most of the studies here are using clinical variables, and there are two that use transcriptomics. The study by Seymour was published in JAMA in 2019 using 29 clinical variables, including demographics, vital signs, and inflammatory markers within the first 6 hours of sepsis, and then using k-mean and consensus clustering with multiple imputations with chained equations to develop 4 clusters, mainly focused on clusters of one being inflammation cluster, coagulation, and one being more of the rapid recovery cluster. Another paper by Bhavani in 2020 used body temperature to develop 4 temperature trajectories. Paper by Lu used 29 clinical variables and spectral clustering to develop 4 clusters of progression septic shock. Kudo had 6 clinical variables with coagulation markers, was using random forest method to develop response to thrombomodulin. Among transcriptomic study, Davenport and Ancliffe previously developed transcriptomic types to look at their validation in different cohorts and developed two clusters of immune response based on immunocompetence versus immune suppression. Interestingly, we look at the study that used clusters to define whether a cluster can help us develop better grouping of the patients who would respond to different treatment. These studies use their developed clusters and apply them to certain clinical data and look at to respond to different therapies. And some of them found benefits, like a Gary study used hemodynamic states using transesophageal echocardiogram really to classify patient in something we empirically know as being systolic dysfunction, RV dysfunction, no dysfunction, and dry patients, and said, okay, if you understand pathophysiology, cardiovascular response, you know who is going to get response to therapy. You would assume that a good intensivist would know how to do that. Perhaps we do need an automated way of doing that based on our echo, and I think this is something that we will see emerging with the devices we use, some automation in classifying patient underlying pathophysiological type. Again, Seymour look at the patient's response to different in early goal-directed therapy, recombinant activated protein C, and found that their subtypes really help them identify patients who might respond to therapy. Similarly, thrombomodulin was found to be more efficient if used, the cluster developed by Kudo. In the transcriptomic studies, Ancliffe showed that the hydrocortisone response was better determined based on transcriptomic clustering. And similarly, study by Zhang that I will review with you also found out that hydrocortisone response was better calibrated if you know which transcriptomic subtype you belong to. This is the study by Seymour because it was one of the better study using clinical data for clustering. He used several clinical variables, including vital signs in the first several hours of sepsis, and found out 4 phenotypes, one being most common, that was probably with less organ dysfunction, and then 3 more severe phenotype that had, as you can see, progressively worse mortality expectation, one being with more chronic illness and renal dysfunction, one having more inflammation, pulmonary dysfunction, and one having more septic shock and liver dysfunction, being the delta phenotype being the smallest. Now, what you will see is that not many of these papers have offered you ability to take those phenotypes and apply to your data set. For that, you will need another classifier to determine belonging to the cluster type. The recent paper by the Zhang and Chen is an interesting study from China that used publicly available transcriptomic data sets and then used deep learning autoencoder to homogenize data and then cluster them to develop and found 2 clusters, as you can see here. And these 2 clusters mostly had highly suppressed immune response as a characterization of the difference between them, so really identifying more immunosuppressed based on 5 genes that you probably never heard of. These are 5 genes: STOM, USP4, ECNA, pylora, and C14, with really not clear action, but these 5 genes with the H together, they use them to classify patients in 2 groups and then show that the only drug that responded to this cluster was hydrocortisone, and if you had this class 2 that was more immunosuppressed cluster based on transcript and these 5 genes, you would more likely to be harmed by hydrocortisone. So perhaps this is a cluster of patients who are more immunosuppressed and do not give them hydrocortisone. This is where we really are with all of this. So one small study that we did in a prospectively was more of the question for us, how, what can we find if we cluster everybody? So we used 243 surgical patients with the derivation validation cohort. In the derivation cohort, we did 42 blood and urine biomarkers within 24 hours of sepsis. based on different subgroups, biomarkers like cardiovascular, kidney function, respiratory, liver, endothelial. Most of them are all available in the first 24 hours. And then what we found is that you will have two big main clusters, and these are just visual representation of these biomarkers, with the red being really hyper elevated, and then blue more calm for their representation in the cluster. You can see that there is one red cluster, a really small cluster of highly sick patients in the first 24 hours, where you have a complete derangement, and we call that early severely disturbed homeostasis. And then you have the cluster two that in the first 24 hours you don't see this derangement of the multiple control systems in the body. And then you can see that within each of these big clusters, there are other subclusters that are smaller. And we explored some of the differences. The study is really small, so we didn't want to go into details. But it's interesting. It gives you idea for hypothesis generation, because within these three subclusters that are more, less disturbed in the beginning, you can see some separation in terms of the immune response and endothelial dysfunction later on. But what was interesting is that really within 24 hours, these early disturbed homeostasis patients are clearly distinguishable from the others. And a lot of them had a lot of kidney problems and a lot of septic shock, and that is nothing really surprising there. They're more, all of their outcomes are worse. So really, I think both clinically and perhaps with the data, I could say with certainty, we have ability within 24 hours to really identify those that are the most sick patients. The question is how many of them you need now to drill in the mechanistically what could be underlying mechanistic difference in terms of this group, or is it the same one, and how we could look for new drugs for these patients, or whether we simply can't. And then the second group is probably much more difficult, in my opinion. So for me, the challenge is I summarize like three. Another thing I want to tell you about this study, what we then did is we developed a classifier that will predict in your unseen data which cluster your new patient belongs to, and it performed relatively well. We have a validation cohort that was a little bit different that we have a validation cohort that was different than development cohort in terms of prevalence of certain disease, but still our classifier was relatively reasonable. So that means that we could really, if we do well-developed study and big data set, we could develop a clustering algorithm and then develop a classifier. Then we can use wherever we go and say, okay, this is you belong to this group of clusters, and then so on. I think that is the future. And I'll talk about it here in my closing slides, the reproducibility, causality, and utility. To reproduce this, the problem is that everybody has their own data set, they apply their clustering algorithms, and then we get all of these classifications, but we really don't have very good ability to validate them in different data set because we don't have a classifier that tell us this is the cluster. So I think we need more aggregation of these approaches, and rather than generating over and over new subphenotypes, we should probably focus on validating a single set of septic subphenotypes across multiple data sets. So this is a perfect opportunity for developing something large scale, and probably even without necessarily sharing the data, and then validating with a new classifier. And then I think the ideal phenotyping algorithm must impact clinical decision making in real time. So it should be parsimonious. We can't test million variables. We should find something that is simple. So, and then it has to be better than what we had. It's a SOFA and Apache. And then I think that's a step forward. First step to then look at the biological plausibility, mechanistic models, building agent-based modeling of all these diseases, and looking at the clinical utility, and really looking for the new drugs in this area. And this is what we need. We need new treatment options. And whether more data and better methods is what we need, or something else, I think time will show. I think we need a little bit of everything. Thank you so much. I hope I'm on time.
Oh, Azra, thank you for a fantastic presentation, and also lovely to see you. Thank you so much for giving up your time and speaking to us.
Absolutely.
And yeah, hopefully one day we'll do these things face to face again when the world gets back to normal.
Yes.
I was told I'm not allowed to ask questions, but I'm going to do it anyway if you don't mind. I have one little question. I mean, you speak. Very interesting to see that you're saying about making a predictive model to see whether or not something can whether which cluster you're in. And the sort of sub question is, can we do this in Mimic and Amsterdam UMC databases? But to what extent, how far? I mean, the clusters you're finding or that have come out in the literature are often from transcriptomics. They're from the inflammasome or some kind of other things that we don't measure routinely. Even in intensive care, we measure so much, but we don't measure routinely. So, to what extent do you think that we can make progress with routinely collected data, or should we maybe put some money into just start measuring more stuff, even if it's not actually clinically useful at this point, but might generate a big data set that in the future we might mine for better insights into these clusters?
Yeah, it's a great question, Ari. I think we have enough data, we have enough literature to tell us that perhaps some of these readily available data can be used for clustering, right? I mean, that's clear to me. I think what we really need to work on is putting all this together as a group across many centers, right? Like we need to give up on fame and going more on a crowdsourcing, at some point, because, for all of this, I think the massive data will matter. The massive data will matter. The new computational approaches will matter, and for them, you will need the massive data. And then mechanistic, how do you go in a mechanistic? It's a very difficult question, in my opinion. And, because I have not been yet convinced that how we overcome the desire to make this commercial. How do we overcome desire that, there is, especially in the gene data, this is expensive. This is how we overcome the desire. I think as a community, the clinical phenotypes would probably be easier tasks. We all have them. And it will be something that we all can do very easily across the spectrum of you guys have done amazing work in creating very good network that resembles Mimic. We have Mimic here. Now everybody, we're going to have a bridge to AI with a clinical, I think with the critical care cohort, with our application. We are hoping to get funded with the chorus cohort. So that will be another 100,000 patients with the text and imaging. So I think the big data sets are coming. Mm-hmm. It's now time for people to get together. And, the methods will come. The methods will come. The very unique new methods are coming. And I'm excited about that.
I agree. It's all about data sharing and we can't be siloed anymore. Yeah. Azra, thank you ever so much for speaking to us. Fantastic presentation as ever. Thank you.
Good seeing you guys.
What we'll do now is we'll carry on with another 3 presentations from our finalists. And the next presentation will be by Team 5. Fatima will be presenting for Team 5 the Datathon desserts on the subject of AKI. I think that's... Oh, no, I'm sorry, Celine. My apologies. I've got you out of order. Team 2 from Belgium, Celine Vens, talking on AKI, Team Faint.
Yes, okay, thank you. Indeed, I'm Celine Vens presenting for Team Faint. We have focused on machine learning tools to provide insights in the initiation and outcome of renal replacement therapy. As my title may suggest, we have just focused on end-stage AKI, which is characterized by the need for RRT. Now, RRT is an invasive technology with impact on morbidity and mortality. It's also time-consuming and costly, and of course, it has an important impact on the quality of life. Nevertheless, the decision to start RRT is based on many parameters, and the decision-making process is kind of fuzzy, we could say. There's also no consensus on the optimal timing to initiate RRT, despite the extensive literature on the subject. So we hypothesize that machine learning may actually provide additional insight in this clinical decision-making process and may further aid clinicians in predicting outcomes after RRT. So concretely, the research questions we have focused on, well, here you can see a timeline of ACU stay, where at some point in time RRT is initiated for the patient. So first question that we addressed is, what can we tell about this population of RRT patients? Are they different from the general ICU population? Secondly, we focused on the part of the timeline before the RRT initiation, and we want to find out which are the variables that trigger the initiation of RRT. Also, we want to investigate whether we can predict whether RRT initiation is imminent for a particular patient. And then lastly, we focus on the part of the timeline that comes after RRT initiation. More precisely, we focused on the question like which outcomes can be expected for a particular RRT patient. So to tackle these questions, we started with data extraction. We extracted all RRT patients from the Amsterdam UMC database. In particular, we took demographic, laboratory, and clinical variables. You can see a more elaborate list on the slide. We first did a small descriptive analysis and then did some data pre-processing consisting of outlier removal. We also handled missing data. So we first deleted the features with too many missing values, or also the patients with too many missing values. And then the remaining missing values were either imputed with the mice tool or were recorded as being missing. The latter was done if we suspected that the missingness might be informative. Finally, we aggregated time-dependent features over a window of 24 hours. So we took the min, max, and average value of these. Then how did we handle our prediction tasks? So first of all, for predicting imminent RRT, we extracted two sets of data. A first set of data consists of, that composes our class 1 data. So these are patients that are close to the RRT initiation. So we took patient data from 1 day prior to RRT. And then to compose our second class, we took other time windows that are much earlier in the timeline, so 5 until 10 days prior to RRT. So this composes our so-called negative set, our class 2 patients. They are not in immediate need of RRT. And then we constructed a classifier model to be able to distinguish the two sets. The models that we used were random forests and logistic regression. To predict mortality then, we focused on the patients that had received RRT, and we looked at the time period just before RRT initiation, and we predicted whether they or when they would die, actually. So this is then treated as a survival analysis task, predicting time to death. For the patients for which we didn't find any death date, we censored them and took the last date of any ICU discharge that we could find in the data set. So for this task, we have used some state-of-the-art machine learning models specifically adapted for survival analysis. So we used random survival forests, XGBoost, and also Cox regression. For all these analyses, we conducted a 5-fold cross-validation, making sure that there is no patient leakage between train and test folds. And then we applied SHAP for interpreting the resulting models. So some results then. First, our exploratory data analysis. So the first graph shows you some information about RRT patients and when did they receive RRT. We left out those patients that had RRT at admission or that got it in the first day because we wanted to extract data from the day prior to RRT. And this led us then to a set of 881 patients. On the following plot, you can see that the RRT population is generally a bit older than the general ICU population. Here you can see that the death rate in RRT patients is much higher than in non-RRT patients. And then finally here you can see the time until death for the patients. So in red, you can see the actual time until they deceased. And in case of no available date of death, we have plotted their last discharge date. You can also see a Kaplan-Meier survival curve for these patients. For the prediction of imminent RRT, on the left side, you can see that random forests actually outperformed logistic regression in this task. And we also see that we obtained a very high predictive performance. So about 91% area under the ROC curve and 86% area under the precision recall curve. On the right-hand side, you see SHAP summary plots giving some insights in the model and the importance of features. For those of you who are not familiar with this kind of plot, let me briefly explain. So you can see the most important features here. They are sorted according to their importance. And then each dot you can see corresponds to a particular patient. The color indicates whether the feature value was high or low for that patient. And then the position of the dots indicates the contribution of the feature value to the outcome. So the more to the right, the more the feature contributed to a high risk of RRT initiation. So we can see, for instance, that the most important variable was fluid balance. A positive balance there gives an indication of higher risk for RRT. Now, important here is that apart from some suspected renal features like fluid balance, creatinine level, acidity, bicarbonate, we also noticed that there are some non-renal features that contain high importance, like lactate values, ventilation, or bilirubin presence. Regarding then mortality, we obtained a C index of around 66%. XGBoost was slightly more performant than the other two methods. And also here you can see the SHAP plots for the most important features in this prediction. Again, fluid balance stands out as the most important feature. There are some other ones appearing here that we didn't see in the previous plot. So these are the main results of our work. To conclude, well, we have shown that machine learning can actually lead to an excellent ability to predict imminent RRT. Prediction of mortality seems to be a bit harder. We hypothesize that this is due to the lack of comorbidities in the data set, which are of course highly important to predict mortality. We've also seen that these prediction tasks are multifactorial and are hence not only related to purely renal features. We also believe that getting insights in this clinical decision-making process and also being able to predict outcome after RRT initiation are the first steps towards a computerized decision support system for RRT initiation. We also plan to make our GitHub library available in the near future. So with this, I want to end. I want to thank you for your attention, with a special thanks to the organizers for giving us this opportunity to collaborate, and of course to my team members for the pleasant 4 weeks that we had. So I'm welcome to take any questions.
Celine, thank you very much, and a really nice presentation. And I'm getting more and more nervous actually, because I think it's going to increase. I think with every paper, every presentation that comes along, it's going to get more and more hard to judge this. Can I ask a question? I mean, I think so. Everyone has done something that's publishable here, which is really, really frightening. Can I ask a question? I mean, one needs to just bear in mind what you're predicting actually is a clinician behaviour ultimately. And you said that was maybe a bit nebulous, but in fact, I think that what you've proven is that with your high C index, or your high discrimination, is that actually it's not nebulous. That it is very predictable what clinicians. I mean, maybe a little bit complicated what clinicians use, but then within that paradigm, what stands out to me that's a bit different is ventilation status as a prediction for RRT initiation, because it's slightly. Why would a clinician pick that? That does seem to be something physiological. Any thoughts about
Yeah, we've also thought a bit about that, and we believe that, well, ventilation status, if it's yes, this probably means that the patient is more ill. Maybe there are multiple organ failure. It could also be related to the wetness of the lungs. So we believe that this could indicate, and that, yeah, RRT is.
But it's interesting that comes out even when having adjusted for a lot of other things that should tell you about how sick this patient is, and were there other oxygenation status, AA gradient reflective things in your predictor set that didn't come out, or was ventilation status the only ventilation parameter?
It was the only ventilation related parameter, I believe, at least in our top, top 20 or top 50 most predictive features. Yeah.
I mean, there is obviously a logical, reason potentially there as well. So, interesting.
Similarly, I think the potassium feature was not predictive, right, of initiation of renal replacement therapy.
Indeed, it's not in this list here.
Which is what we classically teach as one of the 3 indications, right? So that people don't seem to do that in practice then, or at least not as prominent as a feature. But it was there in the mortality prediction, interestingly.
Yes, indeed. There seems to be indeed distinguishing difference.
It would be interesting to look at the sort of entropy, if you like, of that parameter. So what the spread of how many hyperkalemic patients were there, or really hyperkalemic patients were there in that group. It's interesting though. As often with these things, looking at the data throws out a lot of questions as well.
Yes, indeed, and we would be really interested to take a deep dive into what this actually means, and there's still a little bit of work to do to reach solid conclusions.
But I think you should do that. But one thing to go to mind: isn't the performance just too good to be true, or do clinicians just think all alike? I mean, these are really impressive area under the precision recall curves, right? I mean.
Yes, indeed. And actually, last time I presented, our performance was not that high, but so we included some extra features also based on your suggestion, and like with inclusion of this fluid balance, for example, really stood out as being a very important marker here.
Well, maybe we may all be clones. It's true. Thank you, Celine. Fantastic, really results. And I say I think so far every single presentation has got something that's publishable, even with a little bit of tidying up. So I'm getting worried. Right. Okay. In that case,
thank you so much.
Thank you. Let's move on. The next team, if I'm reading from the right list this time, is Team 4, Team Alberta, and Ken Paha is going to be presenting on ventilation, so association of low tidal volume ventilation, ICU mortality in patients with hypoxemic respiratory failure. Ken, we see your presentation. Over to you.
Thank you very much, and just a big thanks to the organizers for the opportunity for our team to present, and also just acknowledge all the hard work of our team members for the work I'm privileged to present here. So as we're all aware, patients who have acute respiratory distress syndrome, low tidal volume ventilation is really a cornerstone of our therapy, and it's associated with the reduction in the odds of mortality. And what we also know is that the larger the reduction in tidal volume that we apply, the larger the reduction in mortality that our patients with ARDS will see. Now, if we think about all of the patients that get admitted to our ICUs, not all of those patients will have ARDS, yet there's a potential to use low tidal volume ventilation amongst other patients as well. If we think about these patients who are mechanically ventilated, as depicted by the green dots, some of those patients will actually have hypoxemic respiratory failure. This is a broad diagnosis that includes things like pneumonia, aspiration, atelectasis, heart failure, and it's anything that can cause reduced oxygenation. It's classified by a PaO2 to FiO2 ratio of less than or equal to 300. And this is in contrast to a subset of those patients with hypoxemic respiratory failure that actually have ARDS. And they will also have a PF ratio of less than or equal to 300, but will also have a risk factor. We'll have an acute onset of this presentation, and we'll have bilateral infiltrates on chest X-ray. What is really nice about hypoxemic respiratory failure patients is that these are patients that are very amenable to registry or database analysis. And we're interested in the effect of low tidal volume ventilation in this cohort of patients because the effect in this cohort of patients is not well described. So our hypothesis was that low tidal volume ventilation reduces ICU mortality, specifically in patients with hypoxemic respiratory failure. And we also hypothesized that there are patient factors during low tidal volume ventilation that can modulate the beneficial effects on ICU mortality. And some of the things that we a priori hypothesized were things like increased duration of exposure to low tidal volume ventilation, having an increased respiratory rate, the biological sex of the patient, and also what the baseline carbon dioxide level was. So our specific aims during this datathon were to try and assess the basic association between low tidal volume ventilation and ICU mortality in patients with hypoxemic respiratory failure. Our second aim was to determine if there are factors that can modify this relationship between low tidal volume ventilation and ICU mortality. And again, things that we considered were hypercarbia, respiratory rate, biological sex, and severity of illness. And then finally, to determine with these factors using machine learning algorithms, can we actually predict ICU mortality on patients that have had low tidal volume ventilation applied. So our methods were that we constructed a cohort from the Amsterdam UMC database of patients that had hypoxemic respiratory failure. So these are patients who were ventilated for greater than or equal to 24 hours. And they also had to have a PF ratio of less than or equal to 300 based on an initial blood gas. We need to have a measurable tidal volume applied to them. And they also needed to be on a controlled mode of ventilation. We felt this was quite important because using spontaneous modes of ventilation and the associated tidal volumes wouldn't really be reflective of clinician practice and what we're trying to actually dial in on the ventilator. The effect modifiers, which we've already described, were going to be assessed, and our primary outcome was ICU mortality. And in order to interrogate these aims, we would use a combination of logistic regression and Cox proportional hazard survival analysis models, along with 6 different machine learning models. So in this slide, I'll just quickly describe our cohort. So we had 23,106 admissions in the database that was available to us, which included 20,109 separate patients. We excluded any patient that had repeat admissions and also patients that were missing a height, because height was the way that we calculated a predicted body weight and how we standardized low tidal volume ventilation. Any patient that was ventilated for less than 24 hours was also excluded, as well as patients that had PF ratios of greater than 300. These patients won't have hypoxemic respiratory failure. And we also excluded any patient that was never on a controlled mode of ventilation or was not on a controlled mode of ventilation on day 1 of hypoxemic respiratory failure. This ultimately left us with a cohort of 2,350 patients, which we felt were quite indicative of patients which had hypoxemic respiratory failure. And to illustrate that, this is just a simple table that demonstrates some of the characteristics of these patients. Roughly a third of these patients were female. About 40% of them were age 70 or older. They had a non-pulmonary SOFA score of about 7. They were on an average of 50% FiO2. Their mean tidal volume applied in that first 24 hours was 6.7 mils per kilo, and their PF ratio was just under 200. So based on this, our first question was, is tidal volume in these patients, while you're on a control mode in patients with hypoxemic respiratory failure, associated with ICU mortality? And what we found was that yes, there in fact was an association between the tidal volume and the odds of death. We used logistic regression and we set tidal volume as a continuous variable in mils per kilogram. However, what was interesting and sort of surprising was that actually a reduction or an increase in tidal volume was actually associated with a reduction in ICU mortality. We interrogated this finding further, and we instead used tidal volumes categorically in an ordinal scale, dividing all patients up into either receiving 6 to 8 mils per kilo in the first 24 hours, 4 to 6 mils per kilo in the first 24 hours, or 8 to 11 mils per kilo in the first 24 hours. And what we found, and we set the reference as 6 to 8 mils per kilo. What we found was that the odds of dying in ICU were higher in patients that received 4 to 6 mils per kilo. And the odds of dying were a little bit less in patients that received 8 to 11 mils per kilo. And this was both in a crude and adjusted model. We further interrogated this using a slightly different approach where we use Cox regression and a time to event analysis, where we set the tidal volume as a continuous variable in mils per kilo. And again, what we found was that there was this similar relationship between a reduction in tidal volume being associated with, an increase in tidal volume being associated with a reduction in the odds of mortality across these patients. Our second aim was to evaluate effect modification, and we examined 4 different subgroups: patients that had high CO2 or low CO2 at baseline, patients that had a high or low respiratory rate, males versus female, and SOFA scores, the cardiovascular SOFA score, which was high or low. And in all of these cases, none of the odds ratios changed significantly, whether you were on 4 to 6 mils per kilo, 6 to 8 mils per kilo, or 8 to 11 mils per kilo, suggesting that there was no effect modification by any of the factors that we a priori had hypothesized. And lastly, our third aim, we used machine learning models to predict whether or not any of these factors that we have described were associated with ICU mortality. We used 6 different models: ElasticNet, Decision Tree, Random Forest, GAM, Neural Network, and XGBoost. As you can see here, although the machine learning models were reasonably good at predicting, none of them were great, and the area under the receiver operating curve was anywhere from 0.585 to as high as 0.714. Okay, but not fantastic. So what are the limitations of our study? Well, it may have benefited from additional baseline covariates, some of which are in the database that we just didn't have time to clean and include. But there's also some other, and this would include things like medications and diagnostic imaging. Other things are not available in the database, which may improve the specificity of these models. The temporal trends over the course of the included patients may have changed because the patients are included start in the year 2003. And although we've isolated a group of patients that have hypoxemic respiratory failure, there could still be significant heterogeneity amongst this group of patients. And so we may consider subgroups to better delineate this association. So in conclusion, low tidal volume ventilation may be associated with increased mortality, especially in patients with hypoxemic respiratory failure. None of the a priori effect modifiers that we were interested in had any effect on this finding. And machine learning models that incorporated tidal volume size as a method to predict mortality were mild to moderately accurate in predicting ICU mortality. And again, thank you to the organizers and also to the hard work of our team members to allow me to present this data.
Ken, thank you. Beautifully presented. And can I congratulate you on doing stuff with, like the modes of ventilation, which is just incredibly messy kinds of data, as you've probably worked out for yourself. I have one quick question, if that's okay, and which is really, to what extent do you think you have or could control or account for the fact that maybe some of these low tidal volume patients, they just couldn't get higher tidal volumes? Or, was their compliance so bad that just no one wanted to rip their lungs apart, but was scared? Because that's just one thing that I wonder could be a confounder here, that another reason that these patients had worse outcomes.
That's absolutely correct. So it's difficult to delineate whether the patients were receiving 4 to 6 mils per kilo because they were so sick that they actually required such a low tidal volume ventilation, rather than that was being applied deliberately in a similar fashion. So one approach might be is that we would propensity match to see if we could find equivalent patients that that receive both 4 to 6 versus 6 to 8. And
you could do, and compliance could be one component of that. That'd be an interesting process.
Exactly, yeah, and build compliance or the peak pressure or plateau pressure into that.
Yeah, even more great results. I think. Oh, go on. Yes.
Sorry. I just had one more question for Ken, because I was intrigued by the effect modification results. Right. So I from a very quick glance, it seemed like the point estimates were in fact quite a bit apart. For example, for the PCO2 values. Do you think that do you hypothesize that there is no effect modification, or that the sample size was just too small to get it to significance, so to speak?
Great question. So I should clarify that that's probably a more precise way to describe that, is that we could not rule out effect modification by this because the confidence interval does cross 1 and it's fairly close. So if we had a larger sample size, perhaps with a second database or whatnot, then we may be able to demonstrate a difference, and perhaps patients that are hypercarbic may respond differently to low tidal volume ventilation than patients that are not.
Great, thanks.
Thank you very much. Thanks, Ken. We'll move on in the interest of time to the next talk, which is Team 3, the Data Ducks. Chris Sauer from Belgium will be presenting on AKI.
Thank you very much, Ari. Yes, it's my pleasure to talk about AKI and how we can leverage machine learning to actually predict and prevent it. So the kidneys, I think, has been mentioned before, are a very important organ with a number of different functions, and there is a very strong association with mortality in the case of kidney injury. What is important is that if AKI is diagnosed early, there is a potential to actually reverse some of the negative consequences. So this brings us to our approach, where we first started off by trying to early predict the onset of kidney injury, and then to move on towards trying to identify different subgroups and work towards a targeted treatment approach. As you can see, we've come some way, but there's still a lot to be done. So what did we do? We first built 2 separate models, one trying to predict serum creatinine 24 hours before, using fluid balance, drugs, numeric values, and potentially in the future also comorbidities. And then we built a separate model looking at urine output using more recent features, because urine output is more easily affected and more regularly measured than serum creatinine predictions. What we then moved on to do was to combine those 2 models and try to assign them into risk categories, and then check if we actually can also find causality between these observations or not. And ultimately, what we aim to do is to try and synthesize this into a simple online risk tool that can be used on bedside. So where are we currently with the models? The serum creatinine model already looks promising. The associations we found actually make sense, in that sense that, for instance, a low serum bicarbonate level is associated with a worse or with a higher serum creatinine. Overall, performance of the model is to be improved, the R-square of around 0.4. What you should be keeping in mind, though, is that we are trying to predict the accurate serum creatinine value 24 hours into the future. So what is also important to look at is to look at the absolute mean square, is the mean error, which actually is not so bad, around 40. So which means if the model would predict a patient to have serum creatinine of 200, it is probably within the range of 160 and 240. So it's still clinically an important prediction. Results for the urinary output model are slightly better overall on the same scale. We can see that for the error there, we get around 0.5 milliliters per kilograms per hour. And what is interesting to see is that it actually varies the performance of the model depending on the hourly urinary input, urinary output. So yeah, important features. Of course, the previous urine output is very important, but all the other variables are actually also from a physiological standpoint very plausible. So what would we do then? We tried to combine those models by using the individual prediction and then bucketing them into the categories shown here. We arbitrarily decided to make it 7 categories, might be anything, but it's very reassuring to see that actually the predicted risk score in the categories from 0 to 6 actually nicely falls in line with the true risk score that is found in reality. So what would we try and do then? Because clinically we are most interested in, okay, are those kidneys at risk or not at risk? So more into a binary problem for which we arbitrarily decided that we think a serum creatinine level above 200 and a urine output below 0.5 milliliters per kilogram per hour is actually clinically meaningful. And there we can see that the model actually performs really well at predicting patients of not getting AKI, where the model is not doing such a great job yet, is actually correctly identifying those patients that are very likely to develop AKI. This is just one approach. Sure, if we would change the scores and make the bins a little bit bigger, having like a bad, an intermediate, and a good function, those results would probably improve. So next we were wondering, okay, with all these findings, is it actually just association, or do we get some causality, which if we want to prevent is actually what we care for? So for that, we used PowerSharp. We looked at patients who received different treatments, looked at their exposure, extracted the confounders through a propensity model, and then built treatment effects model, predicting the individual treatment effect for unseen patients, both when they would get or not get the treatment. We did this for noradrenaline, vancomycin, and furosemide so far. And I'm just going to show the results for furosemide as one example. So here we can see that for serum creatinine, our estimate is that furosemide, any dose, so the average in the data set, gives us an increase in serum creatinine of the next day of plus 16%, which was highly statistically significant, and that urine output for the next hour would improve by roughly 40%. So those are very reassuring data, actually further helping towards using this model in practice. So where we want to move with this in perspective, once we have further improved the model, is to online publish a simple tool where you can input your key patient parameters and your pharmaceutical therapy you're considering, and then see how the baseline risk can change if you do give a therapy or not. So a couple of things left to do. Model performance is an issue, so we're continuing working on that, and one way around could be to change the time periods we are predicting, so actually making it easier for the model to identify the patients while keeping the clinical importance, look for interactions, make sure that it's actually clinically useful in practice. Multi-center validation, definitely also want to do, and then make sure we actually get these results out there and make it useful for clinicians in practice. Thank you very much. Any questions?
Thank you so much for this excellent presentation. I have a question, but it's not really based on your presentation, but it's about your abstract, because I was fascinated by your approach trying to decipher which drugs can either improve or improve kidney injury or make it worse. And so two related questions. So you tried a number of causal models, but I think the results, they went kind of all over the place. So they differed a lot, it seems, in determining whether given a certain drug was protective or not. But very counterintuitively, it seemed that vancomycin seemed to improve kidney function, whereas it's usually considered to be the opposite. So I was wondering, is this a problem of the causative models, or should we give everyone vancomycin if we're suspecting AKI?
Yeah, I think there are a couple of factors that we should be taking into account. First one is we just used every patient in Amsterdam UMCDB, which means that we have a very heterogeneous data set we started with. I think that the results would get better and easier to interpret if we actually restrict it to sepsis patient or just post-operative monitoring patients. So I think that would explain some of those potential variations. We also have to indeed further look into the results outputted by the causality model, and it suggests that we do not see a harmful effect, that we probably still have some residual confounding living in our models, in that sense that physicians are prescribing vancomycin, gentamicin to patients which they deem able to tolerate the treatment. And it seems we have not yet fully identified all the confounders for that relationship, and therefore it doesn't look harmful. So yeah, there is still some work to be done.
Thank you, Chris. Lovely presentation. In the interest of time, what we'll do is we'll carry on. What we're going to have is a brief intermezzo now by Paul Elbers, who's going to talk about where one might go beyond here, because actually all of the presentations so far have got a lot of scope, and indeed actually quite a lot of those groups that didn't make it to the final 9. There's a lot of scope for work still to be done. So Paul. Well, we can't hear you for some reason.
This should be better, I guess, right? Excellent. Yeah, so as I was saying, I just want to make sure that everyone in the audience, whether or not they participated in the Datathon, but also every team in the Datathon, whether or not they made it to this final, can proceed with using the data in the Amsterdam UMC database. Because as Ari told us, I mean, I actually also think that that probably all 9 of the finalists can proceed to a scientific paper, and we would actually encourage them to do so. But then, of course, you need access to the data, because as the teams may have noticed, you don't have access anymore to the database for the last 2 hours. And I'll tell you why that is, but also how you can regain that access. So you've been working with a database from real patients, right? So they were all treated in Amsterdam UMC, and that is why the database is called Amsterdam UMC database, which has been published in in Critical Care Medicine in 2021. And the lead author, and we should pay tribute to him, is Dr. Patrick Thoral, because. Yeah, so Patrick Thoral is a very special intensivist, because I think he's the only intensivist that can code very well, knows all about databases, and is an excellent doctor. So you don't see that very often, but it's lucky for us to have him on board, because he's been instrumental in making the Amsterdam UMC database available, and that is also why he's going to hand out the prizes as a member of the jury, together with Professor Jean-Louis Teboul later today. Anyway, so he's been instrumental in combining this data from different sources, and you have to understand that this is about 1 billion data points, right? So here you see some distributions of data you can find here, and you've already seen this from the presentations, what kind of cool stuff you can do with that. And so, but the problem, of course, and this is especially a problem within the European Union, that you can only release data if it is fully anonymized, because otherwise the GDPR just says you can't do that, right? And of course, there is always a certain threshold at which you can say, okay, this data is not strongly pseudonymized anymore, but it's actually anonymous. And we have tried to mathematically prove that this data is anonymous, but for that you need de-identification techniques. So that is why some of you may have noticed that you don't have the weight of the patient in there, but you rather have a weight group there. This is one of the examples of suppression and generalization techniques. And by doing so, we try to identify what are the chances of re-identification and make them low enough. And this is very important, so because the chances of re-identification are a multiplication of the chances that you can actually identify someone based on the data you might have, but also based on the intention that you have, but even more importantly, the chance that you have access. And so that is why, even though this is a public data set, it comes with a lot of governance. And this is also, and this is why I'm explaining this to you, this is also why you need to sign a end user license agreement, because then you basically comply with the governance rules and can use this data. So how do you do that? So 3 steps if you want to continue working with Amsterdam UniCDB. So the main thing you remember, go to our GitHub page, because then it's very well explained to you there, as I will show you in a bit. But it basically boils down to requesting access, fill out a user license agreement, then that needs to get approved. Then you need to register at our data partner, and then after approval of that, which takes usually about 24 hours, then you can download the data and get going. And then you should come back to the GitHub, because there's a lot of guidance written mostly by Patrick Thoral and a lot of contributors around the world. Now, importantly, it is very important to know that if you fill out this user license agreement, it requires the signature of a practicing intensivist. So not only your signature, but also someone that can vouch for you, and so that we can know that he or she is actually knowledgeable about intensive care medicine. That way, we try to unite data scientists and intensivists. And you need to have a proof of training on data research integrity. But you can do the free course that is also used for other databases, which is also nice because you can use all the databases at the same time. So Mimic, HireIt, and Amsterdam UMC database use the same type of course that is required. It takes you about 30 minutes to do this course. So just to reiterate, you go to the GitHub, right? And then interestingly, if you've never seen GitHub pages, it starts with some kind of directory. So you need to scroll down a bit, and then you see welcome, version, and requesting access. If you click on requesting access, you'll go to the Amsterdam Medical Data Science website. Of course, as usual, you need to scroll down there as well. And then you see a simple 3-step plan, right? So complete the training course, fill out the signed and combined access and user license form, and submit your application. Now, this is what the application form looks like, and it lists the terms. They're very easily understandable because it just basically says that you are not going to re-identify anyone, and if not, will come after you. And here it's very important that so you sign and use your institutional email address, and also your reference need to sign. So that should be an intensivist, perhaps someone from your team, right? Okay, when you've done that, you just come back to the GitHub, because so you see in this directory, there's a lot of work that's already been done for you, so you can get started straight away. With that, I like to thank everyone, and I hope a lot of people will actually proceed, especially the 9 teams, and I'll hand back the floor to Ari now.
Thank you, Paul. I agree. Really, it would be a real shame if people get stopped at this point. So I think that this is a jumping off point rather than the stopping point. Right. Well, back to the main business. Another 3 presentations, starting with Team 5. Fatima is going to present on behalf of the Datathon Desserts on a comparison of kinetic estimated GFR and Aiken criteria, acute injury identification in critically ill septic. We have excellent. Hi there.
Hello, welcome everyone. Can you hear me? Well.
Yep. Yes. Perfect.
So, okay. So my name is Fatima Haushar. I'm from Hungary, and I'm presenting on behalf of Team 5, the Datathon Desserts. And I would like to start my presentation. Yeah. Okay. So we decided to follow the acute kidney injury track, and we focused on the KGFR as a possible approach to identify patients who develop AKI. We started with this paper. Sheldon Chen published a paper in 2013, and he described a new mathematical approach to be able to analyze kidney function in an acute setting, as assessing GFR is problematic while the plasma creatinine is changing very quickly. So basically, until the serum creatinine reaches a steady state, we can only guess the kidney function, giving a delay in the diagnosis. Sadly, the KGFR formula is not widely used, although it quantifies the degree to which the creatinine excretion has decreased or increased relative to its steady state value. And we wanted to see if the KGFR could help diagnose acute kidney injury earlier than Aiken criteria and estimate its predictive value compared to the golden standard, the Aiken criteria. So during the literature research, we found no studies that compared Aiken to KGFR by its prognostic value and timing of diagnosis. We conducted a retrospective analysis using data from the Amsterdam UMC ICU database. And for this study, we have selected all the septic patients in the database that had a serum creatinine measurements before renal replacement therapy. And we excluded everybody who had nephrectomy, congestive heart failure on admission, and creatinine admission of more than 400 micromole per liter. And also we excluded patients who had missing demographic data. Finally, our cohort had 2,456 patients, as you can see here. We evaluated each patient using Aiken criteria and KGFR criteria. So on the left, we show the well-known Aiken criteria. And regarding the KGFR, we have tested several formulas, including the original one by Dr. Chen and its suggested version designed for bedside use for peak creatinine, predicted peak creatinine. We have found that a useful formula for our purpose is a modification of the original one, which includes the initial creatinine value instead of the steady state creatinine value and normalized for body surface area. All of the details can be found in a Colab notebook we shared with you. So the stages of Aiken and stages of KGFR were then compared on the based on the patient's baseline values. You can see here in this table, we compare their therapeutic outcomes, and we can say that basically all of them were comparable regarding demographic characteristics, the length of ICU stay and mortality, although there was a slight difference in the need for renal replacement therapy in stage 3. 1,417 patients were recognized as developing AKI by Aiken criteria, and 1,275 patients by KGFR criteria. To create a severity classification system comparable with the Aiken criteria, Aiken stages, we had to normalize the KGFR formula for body surface area. And after modifying it, we ran some tests on cutoff values to find KGFR to see which one corresponds better for Aiken stages. So the best cutoff value was between 50 and 60 mils per kilogram per min. And for easier correlation with MDRD, we have settled for 60 mils per kilogram per min to have a reasonable cutoff value. In classification of AKI compared to Aiken, it showed accuracy, sensitivity, and specificity of about 65%, and it showed a moderate agreement, and it was in concordance with other studies' findings that we found. To visualize the data, we show them on these histograms. You can see here that in summary, the KGFR alone recognized the onset of AKI 7.3 hours earlier than Aiken criteria. And if we compare the severity of the disease, if we divide them into stages, we can see that at stage 1, the KGFR gave us more than 16 hours of advantage. In stage 2, it's 8.6 hours, and stage 3, it's 3.8 hours. And after that, we wanted to include very important and probably the fastest reacting clinical criterion, the urine output. So we combined the KGFR and the urine output to see if it works better this time. And this combination identified 1,564 patients with AKI, and it's actually more than 9.6% more than Aiken. And it has a much better weighted kappa value. And we can see that the accuracy, the sensitivity, and the specificity has much improved compared to the previous slide I've shown you. So there is this histogram to summarize that the KGFR with the urine output identified the onset of AKI 6.1 hours earlier than ACAN. And the outcomes of the patients classified to the severity categories were no different. And additionally, we accidentally identified this small but probably a high yield group. These are the patients who developed AKI more than 24 hours after admission. In this case, the and to conclude our work, comparing both approaches to identify ACAN-prone patients, KGFR alone recognized less than ACAN, but found them earlier. And discrepancies between identification of patients with AKI seem to be due to the KGFR not taking into account the urine output. Time-wise, KGFR seems to give greater time advantage in earlier AKI stages, expanding and shifting the intervention window to earlier. Combining urine output criteria and KGFR gives excellent concordance with ACAN criteria in AKI identification. So it gives us tremendous time to intervene compared to ACAN. So what's next? We are planning to validate our data, our results on another database, and in the future, we might test this on a prospective study as well. Thank you for your attention.
Thank you, Fatima. It's interesting, isn't it, that with the current, given that everything is now computerized, there's actually very little reason to not use more complicated formulae if they do actually have some kind of benefit. We don't have to necessarily simplify things to what can be calculated at the bedside. Any questions from the panel?
Yeah, so I'm just trying to understand, but maybe it's just my me making things more complex than necessary. So if this would work, it would be really great, right? Because you could predict it could get kidney injury earlier, right? But I'm trying to understand what definition you actually have used for AKI, because somehow I thought that you defined it as a kinetic EGFR of 16 milliliters per minute per 1.7 meters body surface area. But if that is true, then aren't you using kinetic EGFR to predict kinetic EGFR, which kind of makes sense that it will work well, right? Do you know what I mean?
Yeah, I'm trying to understand. Sorry. So basically, you ask what criteria we use for KGFR.
No, for AKI. So the ground truth of defining when someone has AKI.
Yeah. So actually, yeah, you were right. So we defined it as I've shown you. So it's actually a normalized value to body weight, and we classified it to.
Yeah. So when you say that you can predict very early the occurrence of a EGFR below 60 by using EGFR, what does that then mean?
Sorry, I couldn't quite hear you. I'm sorry.
Yeah, it's a connection, so maybe a bit slow. So I'm trying to understand if what you're predicting does not follow already from the predictor. So if you're saying you're using kinetic EGFR to predict AKI, but you define AKI as the kinetic EGFR dropping below a certain number.
Yes, actually, you're right. So basically, we defined acute kidney injury according to the KGFR.
Okay.
Yes.
Okay. Thanks.
So yeah, but our aim was not to. So it doesn't mean that we predict by KGFR. It's rather meaning that KGFR can show it earlier. So a lower KGFR value can mean that the patient is developing acute kidney injury. So I I think it's the other way around. So we are not trying to predict KGFR with KGFR.
Okay, then so maybe it's just me that doesn't understand too well. So, but maybe Harmjan, Ari, can you help me here? Maybe is it just me? It's just me, or?
So I think the question is it self-fulfilling that if you try and identify a outcome that is defined by KGFR, that KGFR may be more effective at identifying the outcome?
Not necessarily, right? I think it may be, but it requires, I think this definition requires a next step, namely showing that your new definition is as relevant as the classical definition. And if you can show that, then you have a pure advantage, which is 6 hours of earlier diagnosis. But I think that final step needs to be sort of confirmed before you can say this is we diagnose it earlier.
But as I understand, we could confirm it on the table when what I've shown you actually. I don't know if I can share my screen again. So yeah, can you see it? So that's no. Okay, so we aimed to compare it to ACIN, and the reason why we wanted to compare it to ACIN is basically it is the gold standard, and we wanted to make KGFR sensitive just as sensitive as ACIN. So we can say that basically the population that KGFR recognizes and what ACIN recognizes was almost the same.
Yeah.
But KGFR shown much hours earlier those patients who later were shown by ACIN.
Yeah, I get it.
I get it. So the gold standard is for the KGFR is still ACIN criteria.
Yeah, exactly.
Okay. Yeah.
Now I get it.
Yeah, that's good.
Okay, I'm happy.
Perfect. Thank you, Fatima. Fantastic presentation and really nice results.
Thank you very much.
Thank you. We'll move on.
Thank you.
The next presentation is by Team 12, the ominously called The Council. And Sharad will be presenting with the title, Not All Lactates Are Created Equal.
Hello, everyone. I'm just going to share my presentation.
Perfect. Away you go.
All right, let's start again. All right. Thank you for having us. And again, my name is Sharad Patel. I'm an intensivist and a nephrologist at Cooper Hospital. I had the pleasure of working with these wonderful clinicians and data scientists. And our question and our overall objective was to really see, are all lactates created equal? So clinical questions we had. So to really understand, so especially in this, this retrospective data, is to understand what the lactic acid guided fluid resuscitation practice was. And our big kind of our concern about lactate is that it's a complex molecule that's been underestimated to be just signifying dry or not. And I think more and more clinicians are now aware that's really actually just more of a measure of adrenergic drive rather than just true intravascular depletion. So what we're interested in seeing is what was the practice for lactic acid based fluid resuscitation in this group. And we wanted to see, is this practice beneficial or not? And finally, we wanted to see what factors, maybe even beyond lactate, would contribute to the individualized predictions of just short-term organ dysfunction. So what did we do? To look at our real first question is to look at the practices. Is we attempted to perform a clustering analysis of patients in the maximum lactate in the first 24 hours versus fluid boluses that were given. So total balance of fluid boluses that were given over time. And what we were hoping to see is a separation in the clusters and for us to be able to actually look at these patients and how they differed and why, maybe potentially explain why these practices were different. So that was our first kind of overall objective in our method. So our main model was a dynamic recurrent neural network to predict an outcome, which was basically delta SOFA, our marker of short-term organ dysfunction. The delta SOFA came from the SOFA at 48 hours and the SOFA at 24 hours. Our model was interesting in the sense that it doesn't require too much pre-processing. As a dynamic model, it doesn't require too much pre-processing, and the features are actually tokenized to be able to predict our outcomes, which are our ordinal outcomes. Our ordinal outcomes were improvement in SOFA, no improvement, and then worsening of the SOFA scores. And the features I mentioned with the lactate specifically, we didn't look at max or mean lactate. We actually looked at the dynamic changes in lactate over time. Other features we looked at were other labs, vitals, which we'll talk about a little bit later, the patient population, surgical versus non-surgical, age, and gender. Finally, we know that neural networks, especially a recurrent neural network, they're black boxes. And we wanted to see if we could rank the importance of the predictor variables and really look at lactate specifically. Where does lactate sit compared to these other features? Is it the dynamic lactate, is it a better predictor of this short-term organ dysfunction than the other traditional things that we think about, such as respiratory rate, heart rate, MAP, things like that. So we did perform a time SHAP. And so in SHAP, I'll talk a little bit about as far as what that means, but it's really a novel and modern method to provide explainability to these black box models that we often use that give us good accuracies, but sometimes we don't know how the model actually came to those conclusions. So these are our patient demographics. Overall, the number of patients we had was 6,175. And then the surgical, non-surgical split was relatively even. And then we also looked at what the initial lactates were, and we can see what our initial SOFA and the SOFA at 48 hours was in each group. So this was the SOFA distribution. So what you'll notice is that when you look at the negative side, so this delta SOFA, these are the patients that got better. So below zero, their SOFA change was negative. So therefore, an improvement of their physiologic parameters. To the right of the zero, we have the patients whose delta SOFA was positive, meaning these patients' physiologic parameters over those 24 hours actually worsened. And it's a very small subset that the patient's SOFAs actually worsen. Most patients are to the left. And you can see the median is around 3.5 or 4 or so. The median right there is around 3. So most patients actually got better over those 24 hours. This was our attempt at performing k-means clustering on when we plot lactate versus fluids. And the fluids are on the y-axis and lactate is on the x-axis. And those are the two features that we plotted against each other. And the initial PCA, the dimensionality reduction, there was no real major separation in the clusters. And therefore, we did not use this analysis any further because we didn't feel like this would really add much going forward because of the lack of separation of these clusters. We decided on the K based on the silhouette score, and K equals 2 was our optimal one. And again, there was no separation, and we could have decided that and seen that in the initial dimensionality reduction using the PCA. So we did not use this going forward. So how did our model perform? So our outcomes were their ordinal outcomes, right? So we had 3 outcomes. It makes this classification more difficult. We used the ordinal C index as one of our primary metrics, and it ended up being, and this is over time. So on the x-axis, you'll see this is over time as the model is working. And our final around C index was around 0.65 or so, which we thought was adequate because, again, classification of ordinal outcomes, of 3 separate outcomes, is probably more difficult for any model than just a binary classification. And again, the C index is a surrogate of your AUC as well. So basically, how well does this model discriminate between the two classes? And we have the AUC here as well. We have the average AUC here on the left, and the AUCs of the 2 major separate groups thresholds that we were looking at, the patients that got better, stayed the same or got better, or the patients that got worse. And our overall average AUC was around 0.7, which we were happy with, again, given the fact that we have 3 outcomes that we're trying to predict and classify. Our calibration slope, which arguably is our most important metric, again, we're looking for agreement between the predicted probabilities and the actual observed or true probabilities. And the slope is what we were trying to the metric that we're trying to portray here. And a slope of 1 is optimal, meaning that the predicted probabilities have all close to perfect agreement with the observed probabilities. And ours was around 1.2 or 1.3 or so of our slope, which we can classify as a weak classifier, probably a little bit more underfit than overfit. So below 1 or closer down to 0, you would imagine that's overfitting, and above, the further it is above 1, that would be underfitting. So our average was around 1.3 or so, which is, you can classify as like a weak classifier. And given this was a dynamic model, and we were using SHAP values as well, we looked at the mean SHAP values, and the SHAP values were all, we used absolute values, so the negative values were also positive values. And this is kind of the progression over time of the SHAP values in the 2 groups. And we'll go a little bit further into SHAP. So again, let me to really discuss SHAP for a second before I describe this plot. Again, the SHAP value is an explainability method in neural network, in basically just about any model, but it's model agnostic. And it provides us the view of the marginal contribution of each feature for that prediction and for that value. So we separated these groups out. So the delta SOFA less than -4, meaning that the patients that got better, and then between 0 and -3, the patients that either stayed the same and got better, and then delta SOFA greater than 4, the patients that actually got worse. And these features are ranked here from top to bottom. So the top feature, respiratory rate and rectal temperature, are the strongest predictors, the highest marginal strength of prediction towards that outcome compared to what we were actually looking at, which was our dynamic lactate. It's all the way here on the bottom. So it's third to the last, which was surprising to us. And we saw is that the dynamic lactate didn't actually have a strong marginal contribution in those predictions overall. So it was a bit of a surprising finding, but we weren't too surprised with what was at the top of the features as well. Now, overall, our conclusions, I think overall we were surprised by some of these findings. Our clustering process and our clustering objective didn't really work out. I would consider that to be kind of a negative result. We didn't actually use that method going forward because of the lack of separation. Using the methods we did, we weren't really able to delineate which lactates were useful and which were not. So we were hoping to see differences in the SHAP plots in the different groups, the patients who got better, the patients who did worse. Is there a difference in how the lactates looked in those patients based on those SHAP values? And really, we weren't able to really delineate a difference between those two using the methods that we used. Using the dynamic lactate as opposed to just a max lactate, so dynamic lactate in our time series analysis, it was overall really just a poor predictor. Again, just indicate based on the last plot that we had that it was third to the bottom. So it really didn't have a strong marginal contribution overall. And that is our presentation. Thank you very much.
Thank you, Sharad. That's fantastic. Really nice presentation, nice and clear. Any questions from the rest of the panel?
Oh, very nice presentation, Sharad. I think this is rocket science, data science, right? This is next level data science, which is saying something in this datathon. So to make it a little more understandable for our audience, also what I get is what you did is you took a reverse view of what we normally do. You took the outcomes, improved, not improved, or deteriorated SOFA scores, and then tried to determine, looking back, what the contribution of the combination of different factors with lactate contributed to the outcomes, right?
Correct.
And you found that lactate actually appears to be not that important.
Exactly. Or the dynamic lactate anyways was not that important. Yeah. It would have been interesting to see what the max, if we were chosen a max lactate, if that would have been higher in this situation. I've used SHAP plots before, but again, the outcome was mortality. So we were actually looking at delta SOFA, which is short-term changes in organ dysfunction. So yep, that's completely correct.
But it's already a very interesting point, right? Because I mean, people have built their careers on the idea that dynamic lactate is something that we should chase. So
and various study designs.
Exactly, in various study designs. So I think this is already something, rather than skipping over this as a negative result, this is already something very interesting.
Thank you.
Thanks.
Thank you, Sharad. Fantastic. In that case, we'll move on in the interest of time. Brilliant, very nice presentation. And then our last team to present, last but by no means least, is team number 7, Jacky from Japan, another time zone jump. Itsuki is going to be presenting this team's results on optimal hemodynamic management for preventing dialysis requiring acute kidney injury.
All right, it's a great pleasure to have presentation of our findings. I'm Itsuki. Can you hear me? Great. So I'm an intensivist at the University of Tokyo Hospital, Japan. I'm team 7, Jacky. Our presentation is about optimal hemodynamic management for preventing AKID in patients with sepsis using deep reinforcement learning. AKID is associated with higher mortality in sepsis. So to mitigate the risk of AKID in sepsis, the perfusion of kidneys should be increased. However, its management in sepsis is often challenging. So in this context, we aim to optimize hemodynamic management to prevent AKID in sepsis using a deep reinforcement learning algorithm. First, we identified 2,700 patients with sepsis, and our exposures to be optimized were bolus IV freeze, noradrenaline, and furosemide. And we set as a composite outcome renal replacement therapy and mortality within 28 days from admission, so-called as AKID. And we used potential confounders as described. First, the entire data set was split into training and test data sets. Then we applied an offline deep algorithm, CQL, to the training that set 80% of all patients to optimize treatment combination. There are 3 types of treatment choice. First, bolus IV freeze, yes or no, and noradrenaline use, yes or no, and furosemide use or not. But due to the time limit, we used only data within 7 days since admission for the RL model development at this moment. And we used some rewards and penalties for the RL model. There are 3 penalties. First, AKID, that was the largest negative penalty, and oliguria, anuria, or cumulative volume overload were also a small negative penalty for the model development. But we set sufficient urine output was a small positive reward. Then after the development of our RL-based model, to estimate the 28-day AKID risk of our RL-based model compared to the actual clinician policy in the dataset, a counterfactual recurrent network, that's a different model was applied to the test data set. It's a sort of causal inference to estimate the risk. Finally, we attempted to interpret our RL-based model using two methods. First one is partial dependence plots, and second one is Shapley additive explanation SHAP. And here is our results, patient characteristics. Among 2,700 patients with sepsis, 12 patients were on RRT during the ICU stay, and 26% of patients were died. And 69% and 30% of patients were on noradrenaline and furosemide respectively during the ICU stay. And this is a result by counterfactual recurrent network. As you can see, we can visualize and compare the clinical course of each patient between under the RL-based treatment and the actual clinician's policy, like shown red line and blue line in the light figures. And using this CRN model, we did causal inference. And at the individual level, RL model could reduce the 28-day AKID risk from minus 60% to minus 10%. And surprisingly, in the test data set, our RL-based model could reduce the risk of 28-day AKID minus 5.7%. And it's a significant decrease of risk. And we attempted to interpret our RL-based model using partial dependence plot and SHAP. As you can see in the left figures, this is a PDP plot, but furosemide use were dependent on urine output or cumulative balance or lactate. So like we interpret that the less the urine output is, the higher the probability of furosemide use becomes. And also in the light figure shows, this is SHAP plot. We interpret that, for example, it's just an example, but the less the urine output is, the higher the probability of fluid challenge or furosemide use becomes. So these interpretation results were overall consistent with our intensivist impression. So we believe our RL-based model might be varied to some extent. This is final result discussion. Our RL-based model could decrease the 28-day AKID risk by adjusting the possibility of bolus fluid infusion, noradrenaline, and furosemide based on organ perfusion and fluid balance. However, we acknowledge that we have some limitations. Hyperparameters were not fully optimized, and to validate our RL-based model in the clinical settings, we have to do prospective studies. In summary, our RL-based model could optimize hemodynamic management to maintain the perfusion of kidneys and attenuate the AKI severity in patients with sepsis. Thank you very much.
Thank you, Itsuki. And congratulations for putting together a reinforcement learning algorithm. We've said this before in the past, that these are not straightforward models to put together and build and train. So congratulations on that. Your reinforcement learning algorithm, I mean, seems to be doing what you'd expect it to be doing in the partial dependence plots, seem to make sense. And it seems to outperform the clinician, or that will be your claim. Really, what I'm interested in is what is it that the policy is doing that is actually better than the clinicians? What can I learn from your reinforcement learning model?
We did not show, but this reinforcement model tended to use more IV fluid compared to the noradrenaline. So this could be lead to prevent hypovolemic and kidneys.
Okay. Yep.
But it's a hypothesis.
So I mean, for me, that's the really important thing to go and dig into, which is what is the policy that the model has learned.
Mm-hmm.
I'm also, if time allows, Ari, so I'm also interested to learn what is the effect of having a penalty for starting dialysis, because it is something that the doctor decides. But so I think the algorithm will learn to avoid what some doctors do and not what other doctors do. Is this a problem, or what do you think?
RRT initiation is, it's very good question. It's a very good point. So RRT is dependent on the patient select and physician's preference. So it's a huge limitation, but we set RRT initiation is a huge penalty, like minus 100 point. But like overfluid or like origuria is like minus 4 point or something like that. So we are largely emphasis on the RRT initiation, but it's not like physician's preference, not like natural cause. So, but we have anything done like that.
I think with all of these reinforcement learning models, the decision making around what the penalty should be or what's good and what is bad is something that needs investigation in terms of the sensitivity results to it.
Mm-hmm. Yeah, true. But all in all, I mean, congratulations for this result. It's impressive what you've been doing. What we've been doing in a month. So only 20 minutes behind, but now the fun is going to start, right? So because we have two very important topics remaining. One of them is, of course, the prize ceremony, which will be performed by us, but also by two very prominent people, Patrick Thoral, if you've seen him before, and Jean-Louis Teboul, who is also very famous. So wait for that. But we have another rising star for you. He's already here. We've seen him asking questions. It's Harm-Jan de Groot from also practicing in Amsterdam. And the reason he is a rising star is because he is very good with numbers, statistics, and especially R. And what he does with R, he tries to do a lot of meta research. So he's studying the subject of doing research, unfortunately, he has been finding some amazing flaws, and it's probably going to teach us about them now because the title of his talk, and you should definitely watch this, is What Are the Odds? So Harm-Jan, please, the floor is yours.
Thank you very much, Paul, and thanks to the two of you, of course, for asking me to give this talk and participate here. All right, so what are the odds? Firstly, I'd like to thank GE for providing an unrestricted grant to the Datathon and this session specifically. Imagine this. A close family member of yours is admitted to the ICU with a life-threatening condition. Your family member is about 86 years old, and because he is so old, you are concerned about the proportionality of intensive treatment. If his prognosis is very poor, then dying in the ICU, intubated and ventilated, is not a good death. But if the probability of survival is reasonable, the morbidity of ICU treatment may be worth the risk. So you ask the intensivist, what are the odds? What is the probability that my family member will leave the hospital alive? And the intensivist says, well, we have two prognostic models. According to the first model, the probability that your family member will survive to hospital discharge is 25%. According to the second model, it's 5%. So you say, wait, it's 25% or 5% chance of survival. That makes all the difference. Which prediction model is best? Which prognosis should we trust, 25% or 5%? Well, says the intensivist, that's problematic because both models are equally good. Actually, both models give excellent predictions. And now you get a bit annoyed, and as it happens, you know quite a little about data science yourself, and you even recently competed in a datathon. So you ask for the model validation statistics, and here they are. Both prediction model 1 and 2 have been validated in an independent cohort of about 2,000 contemporary patients. Model 1 discriminates between survivors and non-survivors really quite well, with an area under the ROC curve of about 0.88. Model 2 has been validated in the same cohort of patients and also discriminates quite well, with an area under the ROC curve of 0.88. Indeed, from a discrimination perspective, both models perform similarly well. So let's have a look at the calibration of the two models. Here are the calibration deciles and the calibration slope for model 1 in the validation cohort. And we can see that the model is really well calibrated. Indeed, the Hosmer-Lemeshow test gives us no reason to reject the null hypothesis of perfect calibration. This is the calibration slope and the calibration deciles for model 2 in the same validation cohort. Again, calibration is nearly perfect. So let's take a moment to think about what we see here. Patients with a predicted survival probability of about 25% according to model 1 do actually survive about 25% of the time. And patients with a predicted survival probability of about 5% according to model 2 do actually survive about 5% of the time. So how can your family member have a survival probability of both 25% and 5%? Let's take a closer look. Since both models were validated in the same cohort, we can plot the predictions of both models against each other, with the prediction of model 1 on the x-axis and the prediction of model 2 on the y-axis. So here it is. We can see that cases like our family member are not that uncommon. Our family member would not be an outlier in this cohort in which both prediction models were validated. And have a look at this patient. I don't mean this one, I mean this one. This patient had a predicted survival of 75% according to one model and approximately 3% according to the other model. A difference of more than 70% on the absolute risk scale. In fact, the mean absolute difference in predictions between these models is 19%, and the mean relative difference in predictions between these models is 280%. We have two prediction models for survival. Both have good discrimination and are nearly perfectly calibrated. Yet for any prediction by model 1, model 2 makes a prediction that is off by more than 200%. And we really have no way of deciding which model we should trust more. Now, you may rightfully think that I made these data up, but here is some real data. It was published in, this is not the data, this is the data. It was published in 1995 by Stanley Lemeshow in Intensive Care Medicine. He compared the individual predictions of two ICU prognostic scoring systems. Both had excellent and nearly identical discrimination and calibration, yet the individual predictions were off by a relative margin of more than 200%. So this problem we're seeing here is very real. And in fact, what we've hit upon is a very fundamental problem in prediction. Let's unpack it step by step to see if we can resolve the issue. Of course, a person can only die once, so we have to rely on groups of patients to make survival predictions. And the fundamental problem is there are infinitely many possible ways of defining the group to which a patient belongs, of defining the reference class that we use to make a prediction. This is the reference class problem. It was first articulated by John Venn of Venn diagram fame in his 1876 book, The Logic of Chance. John Venn introduces us to a Mr. John Smith, and the question we need to answer about him is whether he will live for another 10 years. Let us then suppose that John Smith presents himself. How should we, in this case, set about obtaining a series for him? In other words, how should we collect the appropriate statistics, asks John Venn. Suppose we know that John Smith is 50 years old. We also know that he is consumptive, he lives in India, he has blue eyes, he is of Irish descent, and he is imprisoned. Of course, John Smith has many more characteristics or attributes. So, asked John Venn, how should we collect the appropriate statistics? How should we compose a sample to estimate his life expectancy? What is the appropriate reference class for John Smith? Perhaps we should take a sample of 50-year-old consumptive persons that may give a decent estimate. Or should we take a sample of 50-year-olds imprisoned in India that may give another estimate of his life expectancy? Which of these two estimates is most appropriate? We don't know. But perhaps we should take a sample of 50-year-old men with TB and blue eyes of Irish descent who are imprisoned in India. That sounds like the most precise and appropriate reference class. But there are two problems with this. Firstly, by making the reference class too precise, we reduce the obtainable sample size to only a few people, maybe one or two. So we can no longer make a precise estimate. And the second problem is, why consider only these attributes? John Smith has many, many, many more attributes that may be relevant, such as whether he smokes, what his occupation used to be, or how many enemies he has in prison. The list of possible attributes to take into account is literally endless. And so we have a reference class problem. We can only collect survival statistics on groups, reference classes. But lumping together people in groups requires us to ignore the unique attributes of individuals. Otherwise, each group would consist of n equals 1. Changing the selected attributes will change the composition of the reference class and thereby change the estimated survival probability. Yet, says John Venn, every individual thing or event has an indefinite number of properties or attributes observable in it, and might therefore be considered as belonging to an indefinite number of different classes of things. One survival estimate is no more valid than the other. But you may think that all we need to do is just select only the attributes that are most predictive of survival. This is not a solution at all, and I'll show you. We'll enter the modern statistical era and frame the reference class problem as a variable selection problem. With modern methods, be it logistic regression or machine learning, the reference class problem becomes a variable selection problem. Almost all of you will know that the number of variables that you can use in a prediction model is limited by the sample size you have. The information in the data limits the independent coefficients that you can simultaneously estimate, no matter which technique you use. Suppose that we have a data set with a large number of patients and a very large number of variables, a bit like Amsterdam UMCDB. For all these patients, we also have outcome data, and we develop a model to predict outcomes. The model development must include some variable selection algorithm because the theoretical number of possible variables can always be larger than the data set. We run a modeling procedure, and we arrive at a model that uses variables 1, 2, 4, and perhaps many others, but not variables 3 and 5. Using this model, the predicted probability of survival for patient 2 is 5%. Now suppose that patient 2 is also present in another dataset, a dataset that includes some patients from the first dataset, but also some other patients. Again, we develop a prediction model that employs the same variable selection algorithm. But now we arrive at a model that uses variables 2, 3, and 5 as predictors, and not variables 1 and 4. Because the composition of the dataset changed, different variables became more important, and others became less important predictors at the group level. Using this model, the predicted probability of survival for patient number 2 is 25%. Patient number 2, remember, is the same patient in both datasets, but is attributed very different survival probabilities, 5% versus 25%, because different variables were selected as being important, because the composition of the other patients in the dataset changed. So this is an extension of the reference class problem. Relevant predictor variables can only be selected at the group level and therefore crucially depend on the composition of the group. If the group changes, the model changes, and therefore the individual prediction changes, even if nothing about the individual itself changes. Are modern machine learning methods better at this? The answer is disappointing. These techniques do not escape the fact that people can only die once and that predictions for any individual person must necessarily depend on attributes or variables that are selected at the group level. Machine learning methods are data hungry, meaning that they generalize more poorly than, for example, logistic regression or other additive models with more hypotheses, with more assumptions in them, except if the sample sizes for machine learning methods are extremely large. Small changes in the composition of the group result in large changes in predictions for individuals. So that brings us to the heart of the problem, which is really a philosophical question. Do individuals have a probability? And the practical answer is no, they don't. Humans are not dice. Dice are six-sided, and you can repeatedly observe outcomes of throwing dice. Humans have not six, but an indefinite number of attributes that can potentially influence survival prediction. Remember the confusion about our family member in the beginning, who had both a 25% and a 5% probability of survival, with both models being equally good. This is paradoxical only if you believe that our family member has a true survival probability as sort of an intrinsic property, a survival probability as a true characteristic that we can try to estimate. It's not so paradoxical if you understand that survival probabilities are always contingent on the attributes that we take into account. And there are always more attributes that we haven't yet taken into account that will profoundly alter the prediction. And when I first thought about this problem and this conclusion, I found it quite mind-bending, and I really didn't believe it. If I see a patient very ill, I know that this patient has a poor probability of survival. Maybe 9 out of 10 will die. Am I trying to convince you that you are wrong about this? Yes and no. Patients like this will die 9 out of 10 times. Patients like this with the attributes that are observable to you. But that is not the same as saying that this specific patient, if this specific patient was put in this specific situation 10 times, he would die 9 out of those 10 times. That would be confusing ludic probability, the probability of games of chance, with one-off probability that is contingent on an indefinite number of attributes. We don't hear about this problem more because we usually use prediction models not for individuals, but for groups. The Apache score was developed to compare the performance of ICUs to make case mix adjustments at the group level and not at the individual patient level. For this, it works really well. And likewise, insurance companies don't care about individual predictions. They want to be correctly calibrated for the group that they insure. The reference class problem is only a problem when we want to make predictions about an individual. And with the advent of precision medicine, the reference class problem will become your problem too. So what are the odds? My answer is this. Any survival prediction is only relevant in the context of the reference class set up by the model with the attributes selected by the model. Any one of an indefinite set of attributes not included in the model can radically change the estimated probability for that individual patient. That is why one patient can have very different predicted survival probabilities from different models that all perform great in validation studies. If you have a patient with a predicted survival probability that you believe is wrong because you observe an attribute not appropriately weighted by the model, you are probably right. All right, I hope this talk has been appropriately confusing, and I hope that I made you appropriately wary of individual survival predictions. If you have any questions, I'd love to take them, but I think we're out of time. So if you want to know more, or if you don't believe me, or if you want to work on this problem, don't hesitate to send me an email. Thanks.
Thank you so much, Harmjan. That was really insightful. So, given the fact that we're running out of time and everybody is anxiously awaiting the results, I'm gonna go straight to introducing the members of our jury, which is of course also Harmjan de Groot and also myself and Ari Ercole. But also the designer of Amsterdam UMC database, Patrick Thoral. Patrick, did you enjoy the presentations today?
Yeah, definitely. And well, I'll start by saying that we really know how difficult it is to create models in only such a short time, 4 weeks, using databases. Most of you didn't know when you started a month ago. So yeah, a tremendous work has been done by all of you guys. So congratulations only by that. So yeah, thank you guys.
So then I think it's probably good that we will first start announcing the third place. And may I invite Jean-Louis Teboul from Paris, France, who is also the chairman of the Congress Committee of the European Society of Intensive Care Medicine to announce the third prize. And then Patrick, you can maybe tell something about why we selected the third place.
Yeah.
Okay, thank you very much, Paul. Yes, it is a pleasure to announce the results of this datathon. And I had the opportunity to watch some presentations, and I also find that it is very, very, very nice. So I congratulate all the finalists for their very nice presentations. I was very impressed, to be honest. I am not, an expert of this data science issue, but I think that it is another approach, and it is very interesting for the clinicians. So I will give you the 3 winners, but in the opposite order. So I will start by the third place. And the third place is for the team 5. The team 5, the Datathon Disters from Croatia. And I watched this presentation, and congratulations, Fatima, for your presentation and for your work. And
Thank you
for
very
this,
much.
For this work, you should know that you are invited to present your work in the Lives 2022 in Paris in next October. And your colleagues from your team are invited for a free entrance, not to Paris Lives 2022, but they can have some seats for one of the master classes we organize every year and for 2023. So they are invited to participate in one of the master classes of their choice, of course, and you are invited to present your work in the Lives 2022. So congratulations. Maybe Patrick, you want to add some words about this work.
So the jury was very impressed by the fact that you employed a novel technique, the kinetic estimated glomerular filtration rate formula, and by applying that using the well-known criteria we as physicians know, the ESICM criteria, it is something which we see potential in using in clinical practice. Of course, if you seek the time together with your team to probably improve the model. So congratulations on getting there. Yeah.
Thank you.
So Number 2 is for the team 12, the council. You know, the title is very provocative. Not all lactates are created equal. So again, you are here, Dr. Patel from Hungary, but you are also invited to present your work in our Lives 2022 Congress in Paris, and your colleagues can have a free seat for any of the master classes they want to participate in. So in 2023, they can choose whatever they want: hemodynamics, mechanical ventilation, sepsis, acute kidney injury, whatever they want. Again, congratulations for your work, Patrick.
Yes, congratulations, Sharad. And what the jury noticed was, while you presented, initially as basically, let's say a negative results study, it is interesting also from a clinical point of view, also based on your excellent presentation and visualization of the data, that the conclusion that lactate may not be that important as we as clinicians often see is a very interesting implication indeed. So definitely something which might be interesting to work through. So congratulations on getting there.
Appreciate it.
So the winner, the number 1, is for the Japanese group, the team 7, GIT Jacky, so from Japan, and they congratulations. Their work is about optimal hemodynamic management for preventing dialysis requiring acute kidney injury, and they presented a very nice work. And because you are the winner, all the team is invited for free in our next Lives 2022 in Paris. And you are invited to present your work as a leader of the team. And again, congratulations.
Thank you very much.
Yeah, and Itsuki, we can't stress enough how much work it is to actually getting a model working in such a short notice of time, but especially a working reinforcement learning model is a tremendous amount of work. And not only that, the way you presented your model, showing the partial dependency plots that actually show that it works similar to how we look at the patient, is indeed a model which would come form a basis for something which might be even thinkable of using in clinical practice. So congratulations.
Yes, thank you so much, Itsuki, and also congratulations on my behalf. So this concludes the fourth ESICM Datathon. I just want to reach out to all the finalists, because it has been said before, but we really mean it. I mean, probably all teams should try and proceed to a publication. It's definitely doable. I mean, we've seen some amazing work. I would also like to thank GE Healthcare for providing an unrestricted educational grants to be able to host these sessions, and of course the ESICM Bureau, who have been instrumental, especially Estelle and Margot for making this happen. So thank you very much. It has been an absolute pleasure. We will definitely be back next year, and I hope to see at least some of the teams back next year. And for the winners, see you in Paris, and for the rest of you, good evening, good night, good morning, wherever you are. Take care, and let's try and provide better care for our intensive care patients with data science. Bye-bye.
phenotyping.